and Dean of the OHSU PSU School of Public Health. It's great to see you all via Zoom today. I look forward to our meeting. Steph, will you start with a roll call, please? Steph, Chair, are you?
Can you hear me?
Barely. You're really faint.
Is that better? Let me see. That better?
Yeah, it's a little bit better. There you go.
Okay, I'll just start off the meeting with technical difficulties.
You're still a little bit light, but we can hear you.
Okay, no one else will have to feel bad if they have technical difficulties. Okay, Oscar Rana.
Present.
Great. David Bangsberg.
Here.
Ebony Clark.
Present.
Good morning. Kirsten Isaacson.
Here.
Brenda Johnson.
I'm here.
John Santa.
Here.
Wonderful.
Super. We have a quorum. Thank you, Steph, and thank you all for joining us. I have some unfortunate news to share with the board as well as those attending this meeting today. Our board chair, Rosenda Shippentauer, has decided to resign from the board. She resigned after our last meeting. I'm sure that you all, like me, are disappointed and shocked to hear this and to lose Rosenda's important perspective on our deliberations and her input. Her resignation has stirred, I think, very important conversations amongst board members between Vice Chair Arana and me and OHA in terms of supporting board member deliberations and input. And we want to foster inclusive conversations with board members and also manage and encourage differences of opinion. And how do we discuss differences of opinion? And we will discuss this in detail during our upcoming retreat. I just want to give you a preview of some of the things we're considering and we'll discuss during our retreat. I wanted to have a buddy system where we're pairing board members as buddies, an opportunity to onboard new members to share knowledge and experience, how the board works as a system of support for all members. We propose to have regular check-ins between members and OHA staff monthly before the meetings, debriefing discussions with board members to hear about concerns about upcoming agenda items or decisions or discussions. We hope to have executive leadership team meetings where we broaden the chairs, Vice Chair Arana and I, and OHA staff to include other interested members of the board to participate on a rotating schedule to have a broader discussion amongst board members regarding upcoming items, points of discussion, issues of concern. We'll also look at how we provide meeting materials and communicate those to identify any questions or concerns, requests prior to the board meetings to get a sort of sense of board members whether there's items that will need more discussion and whether we should encourage more discussion before moving forward to a vote. We'll, in doing so, confirm with all of you that you've received the materials, reviewed the materials, and again, heads up on any issues that you will want to raise or think should be raised in our collective deliberations. And we also will continue our series of webinars and trainings to make sure that all board members are, have the information they need to deliberate on these important issues. These will include anti-racism, health equity, communications training to increase knowledge and awareness of the work of the board. And to also make sure we integrate tribal and other communities to provide a comprehensive understanding of the many dimensions of the work we all do together. If there are additional thoughts from board members regarding these items that we will discuss during the retreat or other concerns, please feel free to email or text me or Vice Chair Rana or any OHA staff. We're always eager to hear if you have concerns or suggestions about how we do our business. I'd like to take a moment to see if there's anything that the OHA staff would like to share.
Yes, thank you, David. I would like to just share a little bit from the OHA staff perspective. For those who may not know me, my name is Trilby DeYoung, and I'm the Deputy Director of HPA. So I work with Jeremy Van de Hey and Steph and Tara to support the board. And, just wanted to say that this was really a devastating event, from the perspective of OHA staff, to lose our tribal representative. And I did want to compliment board members, and Jeremy and I reached out and had one-on-one conversations with everyone on the board, and there was so much thoughtful reflection, and I think we all experienced this as a very serious loss and something that we are going to need to turn to collectively to try to improve conversation on the board with these very difficult topics that we're tackling, leading with race and what that means. They're difficult conversations, but they're necessary conversations. And I'm really encouraged by the readiness that you all have to enter into these challenges. So, we huddled together as staff. There were quite a few conversations with board leadership. I'm very grateful to both Oscar and David for the time you've put into coming up with a lot of these ideas that Chair Bainsberg has already laid out. And I look forward to talking about this with the whole board at the retreat. I think there's a lot of energy and enthusiasm about these ideas, and I'm really looking forward to improving and strengthening the support that we provide to all of you. So thank you for that opportunity to comment on it.
Thank you, Trilby. Any other comments from the board members? Thoughts or reflections?
David, this is
Yes.
John.
Go ahead. Mm-hmm.
Well, I'd just like to thank Rosenda. I certainly learned a lot from her and learned a lot during the period of time she was on the board. And, have a better appreciation for how complicated this relationship is. I heard a radio piece yesterday on, the history of the Nez Perce and how they were treated.
You guys need food?
How they were treated over many.
Would you like a hard-boiled egg?
How they were treated over many decades, and it's just a really complicated relationship that I know we're going to hang in there, and I'll try to do better. And but just want to recognize that Rosenda did make a significant contribution, I think, to all of us individually and while she was on the board.
Okay. Thank you, John.
Yeah, one thing I should mention, David, as well, is that, we have, of course, met with our Tribal Affairs Office, and it will be essential to get another representative from the tribes, and we will do that without any delay. So, yeah, it's very tricky. And one of the conversations that we had was how, with anti-racism training, how important it's going to be to integrate tribal perspective on these issues as well. And Rosenda was such an important voice, and I know I've reached out to her personally, and I'm just so grateful for all that she's given to this board.
Any other thoughts or reflections?
I think for me, this a really big experience and just sort of a big lesson learned about how we approach our work in terms of moving forward with votes and board votes. So making sure, to the maximum extent possible that we have consensus and that we're all aligned in terms of where we're moving forward. So there's been a lot of reflection for me on that end.
Thank you, Oscar. Any other thoughts before we move on? Brenda, yes.
I just look forward to the conversation in January. I think it's really important to honor different perspectives on the board. And Oscar, I appreciate that notion of always striving for consensus. And I think it's helpful for our board to understand and develop principles of what it looks like when we don't, so that we actually honor diversity of voices and still can help support the agency moving forward. So I look forward to that conversation. Thanks.
Great. Thank you, Brenda. All right. Well, with that, we have three openings on the board. So if you have ideas for board membership, please contact one of the OHA staff to put names forward, either Tara Chekok or Steph Jerem. I also have some great news to share with you. Our newest board member, Ebony Clark, who was serving as Multnomah County's Behavioral Health Director, has agreed to step in as the interim health director. Ebony directed Multnomah County's mental health and addiction services since 2018 and served at the county for more than a decade. So congratulations to Ebony for this promotion, this increased leadership role, and her commitment to building trauma-informed organization and her commitment to continuous quality improvement for our county. Congratulations, Ebony. Well done. We're happy for you.
Thank you. I appreciate it. And, I think, again, that role that ties well into, the role of, being on the Oregon Health Policy Board. And so I'm excited to move forward in both of my new capacities.
Great to have you here. Thank you. Today, we will we'll have a director update from Pat Allen. We'll hear from the OHA Government Relations team on OHA's 2021 legislative agenda. And we'll spend the majority of our time today talking about how COVID-19 has impacted community members as part of our ongoing discussions to elevate community voices and to sort of supplement for our inability to move around, to travel around the state, to bring in broader perspectives to our discussions. Following that, we'll hear from public remarks. But before going forward, would like to let people know that if you have a public remark, to please send a Zoom chat message to Michelle Hatfield or text Michelle at 503-551-3881. That's 503-551-3881, or a Zoom chat message, and we'll put you in the queue for public comment. So before going on to today's agenda, I'd like to review the minutes and entertain a motion to approve the minutes.
This is Brenda, so moved.
A second?
Second, Kirsten.
Okay. All in favor? Aye.
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 Any opposed? Any abstain? Thank you. So the minutes pass. So we'll move on to the director's update. Director Pat Allen, I will hand it over to you.
Great, thank you, Chair Bangsberg, members of the committee. A few things to talk about today. Just a quick update in terms of some of our core metrics. Right now, over the last 7 days, we're averaging about 1,300 cases, new cases confirmed and presumptive per day. That's obviously our high during the course of the pandemic. Our deaths are also increasing. In fact, today we're going to be reporting, I believe, 25 new deaths, which is far and away the highest number we've reported on a single day. Hospitalizations are becoming very, very concerning. They are now at a point where they're crowding out elective procedures. And elective procedures is one of those phrases that you say it or hear it and you think of, tummy tucks and facelifts and things like that. And in fact, it's simply surgery that can be scheduled. So cancer surgeries and gallbladder removals and those sorts of things that are, while elective, really, really important. And so that's a concern, of course. All that said, I would, as I said in a press conference last week, I'd still rather be us than a lot of other places. For the most recent 7 days, we're still one of the 10 lowest states for new infections. Per capita, we continue to be, I believe, the 5th lowest state in deaths per capita. And so that kind of puts where we're at in perspective around some of the rest of the country. The countervailing piece of that is that as I look at states that have had extremely high outbreaks over the last month or so, many of them have now fully crested and are on the way back down. And we're at best maybe beginning to show signs of plateauing. Now, I think there are a variety of reasons for that. A great example is Iowa, which is almost down to its pre-peak or pre-wave levels, mostly because they had done almost nothing to prevent COVID in the community. as a state previously. One of the biggest issues, the governor finally adopted a mask mandate, and lo and behold, cases began to fall off a cliff after masks were in much more widespread usage. So but one of the challenges with the aggressiveness that we've been fighting the pandemic here is there are not a lot of tools in the toolbox to go roll out that are brand new that we haven't used and that the public hasn't already been exposed to. A couple of other pieces to talk about. You maybe have seen that we are changing the methodology that we're using to report our testing. Early on in the pandemic, we made a decision to use, CDC has approved 3 different methods for reporting tests. I'll talk about 2 of them. Early in the pandemic, we adopted a person-based test method, basically reporting tests for new people tested. And the reason for that was early on in the pandemic, someone would be hospitalized. Usually you had to be hospitalized to get tested at all, and you would be repeatedly tested. And if we reported the results of each and every test, we would be reporting basically the same person over and over again who was positive, and that would distort those numbers potentially. And so we made a decision to do a couple of things. If you were reported as positive, we lock you out of any new tests for 90 days, that being kind of the window that experts seem to agree is a potential reinfection if 90 days later you again test positive. If you test negative, we lock you out of the system basically forever until and unless you test positive. And so if you look at our test totals up through this week, you can see there are just over 1 million tests. That's actually 1 million discrete people who have been tested over that period of time, or 1 in 4 Oregonians. The other way of measuring tests is to look at the number of tests that have been given, regardless of whether they've been given to the same person over a period of time. So imagine a worker in a long-term care facility who is on a cycle of getting tested every week or every 2 weeks or something like that. Those repeat tests would be locked out of the system under our previous methodology. And there was really no difference between the two in terms of calculating, most importantly, our positivity rate until about 6 weeks ago. And that's because repeat testing wasn't common until about 6 weeks ago. And as new standards for long-term care particularly opened up, but also test availability opened up, you began to see those lines diverge from each other, so that now the positivity rate is significantly different if calculated on a test basis than it is on a person basis. Now, the reason that, and so we're going to move to the test-based method of calculation, and we've begun reporting those numbers as of yesterday. Among other things, it's a more accurate reflection of how much testing we're doing. We've been ranked as the lowest per capita testing in the country, which we knew was not the case. And that change in methodology moves us up to about number 30, so kind of middle of the pack. It also drives our test positivity rate down from, as I've described it, from an emergency to merely alarming. I think we're down in about the 7% range. And if you think about it, imagine that there's a pool of 100 people from around the state who got tested last week, and you calculate a positivity rate for them. Even testing the exact same 100 people the next week and getting a different positivity rate actually is helpful in terms of understanding how much disease is there in the community and how is it spreading. Long-term care isn't the only population that's receiving repeat tests, but it's a good one because they are overweighted toward people of color and people with lower incomes. They're spread across every single community around the state. And so as kind of a sentinel population to be periodically testing, they are actually giving us, I think, a really good read on not only the prevalence of coronavirus in the community, but its prevalence in communities that are disproportionately impacted. So you'll see those numbers begin to show up in the national accumulators and things that are out there over time as we make that change. That ties directly to the last thing I want to talk about, which is our new metric structure or risk-based structure that we'll be using at the conclusion of the freeze, which ends tomorrow. And I think we've got a couple of graphics to share. And if we could pull up the graphic that shows what the metrics are for the different risk categories first. And while we're pulling that up, what we've tried to do is more closely align the school metrics with all the other reopening metrics. As we've built the different kinds of restrictions we have over time, we've tried to really have them be based on our best understanding of the risk of certain activities. Nevertheless, there are a lot of people who look at that and see them as value judgments. If something is open, we think it's important. If something is closed, we don't think it's important. So I get lots of emails about, why can I go to a bar but my kid can't go to school? And the sort of the relative risks of different settings doesn't help a whole lot in that. So what we're trying to do is align that better. Have we got a graphic to share? If not, I can pull something up quickly. Oh, here we go. No.
We may not have that exactly.
Okay, I can share it from my screen. 1 second.
Great.
Okay. Okay, so the first one is the various risk levels that we're going to establish. We're going to try to, instead of having the system we have now where we have phase 1 counties and phase 2 counties, and then we have a separate unconnected system of school metrics, we're going to try to create a single, we have created a single risk-based set of metrics, and then restrictions and openings on activities based on those. I won't go through all of this in great detail, but you can see the general idea is for counties with over 30,000 people, it's a rate per 100,000 population metric in terms of how much coronavirus is out there. The entire state right now is at about 400 cases per 100,000 population. So as a state, we're well above the extreme risk level. I'll show you a map in a minute that gives you an idea of what that looks like across the landscape. For smaller counties, we use a whole number of cases metric. And then for counties above 15,000 population, we also use a positivity metric. And this metric is based on the new system of reporting tests. And so you can see the idea is lowest risk is considered anything below 5%. Opinions vary on what's the right low risk positivity metric. Some argue 3%, but we're in that kind of a general ballpark. Let me stop sharing that and go to the next one. 1 second. There we are. So what we then do is at each of the risk levels, you can see there's a variety. We try to put all of the guidance that we have in one place. It's still supplemented by detailed specific industry guidance that gets into much more of the detailed regulatory rules and those sorts of things. And you can't see it here, but above this lies the existing system of school opening. So at lower risk, schools are largely open and available for in-person education, consistent with the Ready Schools, Safe Learners guidance. Moderate risk is mostly in person. High risk is kind of a transitional category for schools, and then at extreme risk, you're mostly in distance learning. And that lines up then with more and more restrictions. The fewer kids who are in school, the more restrictions there are on other activities, showing that we're dialing those other activities back in an attempt to gain control of transmission and get kids back in school. So we go through things like eating and drinking establishments where you're only able to do outdoor at extreme risk. You get some degree of indoor at lower levels of risk. Party sizes and capacities gradually drop as you get toward extreme risk. Sizes of gatherings drop as you get to extreme risk, and so it goes. Again, I won't go through all of these. I think if we haven't already, we can send you these links. You can see that we've tied in long-term care visitation, and again, tried to kind of get everything all in one all in one place. Last thing I will share is a map. And so this is where we sit. This is as of a week ago. This map has changed a little bit. This is not the updated map. I think we have a couple of more extreme risk counties and fewer in the moderate and high category, but this kind of gives you a general idea of what you're going to see. In part because of lower transmission and in part because of a different metric for counties below 30,000, you'll see the lower risk counties will tend generally to be more rural and sparsely populated counties. Most of the population is in extreme risk right now, and that is for sure continuing to be the case in the most recent week when this map gets updated with the current data. So with that, let me stop and see if there's anything about any of what I've just said over the last couple of minutes that anyone's got questions on.
Questions for the board? Comments? Brenda?
Thanks, Director Allen. My question is not so much about what you've shared, but around if you could give us an update about policy for vaccinations, anything that's emerging in that space. Thanks.
Yeah, thanks. And we can do a presentation in more detail on vaccinations next month if you're interested. We are getting information from the federal government that's still requires a little bit of deciphering. And let me illustrate. We're getting numbers of doses of vaccine we're going to get. Of course, the vaccines that have been submitted for approval so far are 2-dose vaccines, and so you've got to translate doses into people. What we aren't clear about is whether those numbers necessarily include vaccine that will be distributed directly through pharmacies to long-term care or nursing homes, actually, specifically. If that number is deducted out of what we expect to get initially, then that'll reduce that. The CDC has set up a very broad prioritization categories, and they talk about phase 1A, which is healthcare workers. Healthcare workers is a defined category that includes staff in patient contact in hospitals as well as staff in long-term care facilities. And then there's also the desire to be able to vaccinate individual residents in long-term care facilities. We do not expect to get enough vaccine in the initial shipment to cover all of that. Excuse me. So it will require subsequent shipments. They do inform us that they'll be making weekly shipments, but they don't have a good sense of how much. Good news for us is every indication so far has been that those shipments will be based on a per capita, based on population over 18. This vaccine is not expected to be approved for use in kids. That's an important point to make. It will not be dependent on disease prevalence. See my previous reference to our being one of the 10 lowest states in the country in disease prevalence. So that won't cut against us where things like PPE shipments early in the pandemic did, because we took early actions and had lower prevalence of disease. We are right now assembling an advisory committee with a wide diversity of perspectives to be able to help us sort of subdivide the prioritization within the broad categories. Just the categorization generally is healthcare workers, essential workers, at-risk populations, general population. But there's obviously a ton of detail within those broad categories that we need to work on. For instance, I've been getting a ton of email asking that teachers be prioritized even ahead of healthcare workers. That's unlikely, but amongst essential workers, I think there's a real conversation to be had about is there a vaccination pattern that can focus on getting schools open as a priority versus other priorities. That's what that advisory committee will help us work through. Right now, there are 2 vaccines that have been submitted for approval. There's a clinical trial, significant clinical trials going for 2 others. And so I think we're likely to see at least 2 vaccines, if not more. Obviously, the more vaccines there are on the one hand, the more supply there is to be able to get people vaccinated. On the other hand, the more potential for confusion about the second dose there is. There's a registry system and a vaccine card that people will get. But you know, we're going to need to get to herd immunity to vaccinate 3 million Oregonians, and so you know, you can anticipate that that's going to be a challenge in that process. The other piece that's going to be a challenge are the cold chain supply requirements. One of the vaccines requires storage at 80 degrees below 0 Celsius. It's got some ability to be on dry ice for a while after it's been on super cold storage, and be refrigerated for a very short while after that. But it also comes shipped in fairly large shipping units, which will make rural distribution extremely difficult for that vaccine, because you can't dump 2,000 doses in Harney County and think that you can get through them in a day, probably. So there are those, and that number is a little bit made up, but it kind of gives you the idea of the challenge. I believe it's the Moderna vaccine requires sort of ordinary cold chain, which is common for lots of vaccines, and so the capacity for that storage around the state is considerably better. I think AstraZeneca and Johnson & Johnson don't have cold chain requirements, and the Johnson & Johnson vaccine is a 1-dose vaccine if it proves out. We haven't seen data on that yet. So those are some of the logistical complications we're also working through.
Thank you, Brenda, for your question. Thank you, Pat. We should probably move on. Appreciate the update, Director Allen. And we'll move on to our 2021 legislative session preview. It's a pleasure to welcome back Jeff Scrogan, who many of you recall was the sort of lead staff for supporting the board. Jeff, it's great to have you back, and hand it over to you for a legislative update.
Chair Bangsberg, can you hear me?
Yes, good to see you, Jeff. Welcome back.
Thanks. Good to see everybody. Thanks for making time for this. Just quickly, I need to say my boss, the Government Relations Director, Holly Heiberg, sends her apologies for not being able to attend today. She was going to give this presentation, but had an emergency thing come up yesterday and isn't able to join us. So on behalf of her, I'm sorry she couldn't make it. I'm going to run through these slides pretty quickly so we can get to question and answer and maybe make up a little bit of time for you. I'm going to ask the board members to hold their questions until we're to the question and answer section, which I'm going to try to get to as soon as possible. We're going to go through, like I said, go through these slides quickly. The goal is to kind of share a little bit about our priorities as the legislative team. I'd like to show or share a little bit about how our team works and the makeup of the team, and have a couple of team members share some of the high priority legislative concepts that they're working on. And then we can talk a little bit about the legislative concepts themselves and get to any questions you might have. Thanks, Michelle, for sharing this screen. You can see this is just a quick slide on our legislative priorities. There's 3 elements on this slide and a 4th element that's unsaid and missing. And we have OHA's 10-year strategic goal, the elimination of health inequities up front and first. And we have kind of 3 black bullets about this session and how the legislative team is prioritizing engagement and policy development, really focused on anti-racism and health equity, improving behavioral health care, and partnering with community to address health inequities. And then lastly, we have our triple aim at the bottom. I said there were 3 components of the slide, and I'm missing 4th, or a 4th that's not really here. And the 4th that I think we all kind of see on top of all of this is COVID-19 and the work we're going to have to do to continue to rebuild and recover. Next slide. Just the board's health equity definition. Thank you for making this definition, Oregon Health Policy Board. I would like you to see that this is literally embedded in all the work we do and was fundamental to the government relations process as well. Next slide. And so this is our government relations team. As I mentioned, the Director of Government Relations for the Health Authority is Holly Heiberg. She's not able to make it today and sends her apologies. We also have, and I'm going to have each of these folks, or a couple of these folks, maybe spend a minute or two introducing themselves and talk about a key LC or two. And I'm going to start with our Public Health Division Senior Policy Advisor, Angela Albee. Angela, are you there?
Yeah, thanks, Jeff. Hi, everyone. It's great to see so many familiar faces and names. And thank you for the time today. Again, as Jeff said, I'm Angie Albee, and my portfolio includes the Public Health Division and all of its many programs. And just to give you a highlight of some of the, the priorities for the Public Health Division right now that lines up to all of what Jeff presented. Of course, in our agency request budget, we have the public health modernization investment request. And of course, if anyone has thought about the many ways 2020 has proven that public health is incredibly important, as well as creating a robust system, I think this is the year. And so between our response to COVID, between wildfire smoke and so many other issues, we know that we really need to have that investment in public health modernization. And I know so many of you have been great champions for that as well. We will wait to see what the governor's recommended budget will include. And we're looking forward to, kind of seeing how that rolls out over the next couple of months. We also have a couple of tobacco legislative concepts that were both recommendations that came out of the governor's vaping work group. And those include the tobacco retail licensure concept, as well as a flavor ban, so prohibiting the sales of flavored tobacco products, including menthol. I know that we have so much to get to in so little time, so I am available for questions. We have many other LC's legislative concepts that I would be happy to answer questions about or talk to you more about. And I know many of us have already had the opportunity to do that, but please feel free to reach out. And thank you so much, Jeff. Back over to you.
Thanks, Angie. Okay, next we're gonna look at our health systems division. These are the folks that really have the regulatory authority over our CCOs and our organ health plan, fee-for-service population. It also includes our behavioral health portfolio, and that's Annalise Dolph. Annalise, are you with us?
Yep. Good morning, Annalise Dolph. Thanks, Jeff. Good to see everybody today. I will be quick, as is our theme here. So in the health systems division, our Medicaid unit actually didn't have any legislative concepts. I think you'll be hearing soon about elements that are or are not in the governor's budget, but in terms of legislative concepts, we didn't have any this year. The theme, I'll say, on the behavioral health side is very much short, how do I say this? Technical corrections. We have some very weedy concepts, both from the state hospital and from HSD behavioral health. Fixes, if you will, in our behavioral health system, some things having to do with suicide data reporting, how we use our recovery housing dollars to ensure that they're for low barrier housing. The most substantive piece that I will share from our legislative concepts is a concept, it's 419, that comes from the Governor's Behavioral Health Advisory Council. And that was a group that started meeting before the pandemic. The governor called folks together last fall. I think you all have heard about this before, to really look at what we need to move forward in our behavioral health system and to improve access. And that group came up with a number of proposals that then went to the Governor's Racial Justice Council, and some are reflected in the governor's budget. But this concept really kind of takes a holistic approach and puts all those recommendations together. So I'll just note real quick that they're in 3 buckets: workforce, housing, and programs and services. So there's some real innovative ideas and some things that are really just putting the puzzle pieces together to start to bring together our behavioral health system in a better way to serve people. So that's a really high level summary there. I'm happy to answer any questions as we move forward. Thank you.
Thanks, Annalise. I'm next on the list. I'm Jeff Scroggin, and my portfolio covers our health policy and analytics division. So things like PEB-OEB, health policy, health analytics, and delivery system or service innovation, like the Transformation Center. I also am helping in covering down on our Office of Equity and Inclusion. That's Leanne Johnson and her shop. And so for a couple of our priorities, I think the 2 LCs that I would flag for the board of interest potentially are, and this shouldn't come as no surprise, we have a piece of legislation, a placeholder for the healthcare cost growth containment and sustainability benchmark work, and that would be to implement the implementation committees, recommendations as approved by the board regarding accountability and enforcement. So as you'll all recall, Senate Bill 889 directed the healthcare cost growth target work to begin and called together an implementation committee, and then also required a check back with the legislature statutorily regarding any enforcement and accountability mechanisms. So we have a vehicle to do that. And then on the OEI side, I thought it would be good to share we have a legislative concept to statutorily define and expand our regional health equity coalitions, or RHECs as they're called. Regional health equity coalitions are a great source of local, independent, and history-based and person-based and science-based equity policy expertise. So very helpful throughout the state in healthcare policy development to have local RHECs. So there's just a couple LCs from HPA and the OEI side that we'll be looking at for this session. I wanted to also introduce a couple of our other folks on the team. Matthew Green, are you with us?
Yes, I am. Hi, I'm
Matthew is gonna, go ahead.
I'll go for a second. Yeah, I'm Matthew Green. I focus for the team on fiscal and budget issues, and we'll know a lot more when the governor's budget comes out. I work on those issues. My early prediction, and we'll see when it actually comes out, is that it includes some very targeted investments in public health and behavioral health, as you've heard, although not everything that we might be hoping for, given the current fiscal condition of the state. So I'm just kind of leave it at that until the governor's budget comes out.
Thanks, Matthew. And then Belle, are you with us?
Yeah, hi. Belle Shepherd, so newest to the government relations team and kind of covering a smattering of things, been working expressly with the Real D implementation work, so the race, ethnicity, language, and disability data project. Be continuing work on that if there are legislative concepts that come forward. Also oral health, vaccines, and then working with tribal affairs on their traditional health worker LC. Thanks.
Thanks, Belle. Okay, I think we're ready to move to the next slide, Michelle. Great, this is a list of our legislative concepts, and I think this is where we're gonna likely spend the rest of our time with you today. But I just wanted to talk about a couple of the other elements in your packet as it relates to this agenda item. At the very end of your packet, we heard a request to hear about how the election went and what the outcome of the election was. You can see some measures have passed. We welcome any questions you have on that and some of the legislative outcomes as it relates to supermajorities in the legislative bodies. So we included that at the back of your packet. And also happy to talk offline about any questions you have. I'll come back. Also, we've included at the front of your packet, right after our PowerPoint, a draft narrative of all of these LCs. You can see this slide has got 2 or 3 words on every single legislative concept, which is just enough to maybe trigger what this concept is about. And then the next document in your packet kind of has a paragraph or 2 on each concept. And then the next document in your packet, the third out of the 4, is some 350 pages, I believe, and is every legislative concept you see on this list included in your packet. And this is a kind of a big deal for us. We're really excited to be able to share all of these LCs with the board and with stakeholders. And we're anticipating continued engagement around our priorities and these LCs. And for any folks listening on the phone who have any questions, please feel free to reach out to the government relations team. You can see earlier in the slideshow, we included emails for everyone's specific area. There's no wrong door though. Feel free to email any of us any questions you have, and we'll be sure to get you where you need to go to get that question answered. Okay, so I think we do have about 5 or 10 minutes for questions. I defer to the chair on how much time he wants to give this, and I don't know how much questions, how many questions you have, but Michelle, can we go back to that previous slide? Because I think it's a good reference point on the LCs, and we've got the team on the line and on video. Is there any questions or comments from board members on our legislative agenda?
Jeff, we have time for questions. We have about 7-8 minutes.
Great.
Let me open up to the board. Jeff, thank you for introducing your team, and it looks like you have a very ambitious agenda.
I have a question, Jeff. So I'm looking at number 28, Legislative Concept 0449, about creating a tribal traditional health worker category. I'm curious to know more about that, and I'm also curious to know more about how OHA works with the tribes to sort of move a concept like this forward.
Thanks, Oscar. Great question. I'll ask Belle. Belle, I'm going to ask you to speak to this just for a second if you can, but beforehand, I'll buy you a couple seconds. And I think we work with Julie a lot and with tribes. And this concept was worked with both of those folks, with our tribal director, and I know she worked with tribes, but happy to have full presentation on this. We can come back and kind of dive in a little bit more, Oscar, if that's of interest. Belle, did you have anything else to add on this LC?
Yeah, thanks, Jeff. Great question. Really, this is wanting to add that tribal perspective into the traditional health worker category. So it's adding an additional category. There's already 5 categories. This would be putting this tribal one specifically in there. So we're looking at any medicine practices that tribes would already be utilizing, how there's a billing mechanism for that, how they might be connected best to traditional health systems, but also to tribal systems. So really relates to some of the other work that's being done. You know, I think what Jeff said is we work with tribal affairs to help develop these pieces. They work very closely with the tribes. Of course, Pat, if you want to suggest more around that, you've done a lot of that work, but that is really coming with tribal leadership in mind.
Thanks, Belle.
I have a question. This is Ebony. Was hoping to hear a little bit more about just where things are at with the placeholder for aid and assist, and then wanting to get, you know, hear a little bit around the context specific to the criminal justice data and behavioral health outcomes. And then, you know, my other question was, you know, I'm thinking about kind of Measure 110, and do any of these fit in with that?
Well, those
Thanks
are
for that.
just
Good
like
question.
oh, sorry, Jeff, don't want to talk over you. Ebony, thanks for those softballs. I think we only have about 5 minutes left. So this is Annalise. The aid and assist placeholder is simply a placeholder. At this point, I don't anticipate that we will need it. The Oregon Judicial Department is leading the bill this year. As folks may or may not remember, we had Senate Bill 24 in 2019. A large implementation group kept meeting to see how the implementation of that was working. The group came up with legislation in the 2020 session, Senate Bill 1575, that did not go forward because session ended. And so that work group has continued their work. And so the only bill I anticipate with aid and assist is the OJD bill, but we have held on to this placeholder just in case we have anything that we need to move forward. And then LC 430, the access to criminal justice data for behavioral health outcomes, that relates to the work that we're doing with our MOTS modernization, Compass modernization project, and building a behavioral health data warehouse. We're working with the Office of State Police to gain access on a very limited basis to Oregon criminal records, which we don't currently have access to, so that we can better track outcomes for those dollars that we are spending on jail diversion, aid and assist, et cetera, so we can better track outcomes for those folks. So those are those LCs. I don't know if we have time to talk about Measure 110, if you want me to spend a couple minutes on that, Jeff, or hold off for future conversations.
Can you just say a word, Annalise? And I do think we'll probably have to have a future conversation.
I can't pick just one word. Just kidding. So Measure 110 is a pretty heavy lift for folks who haven't reviewed it. You probably want to. There's a couple components to it that happen very quickly that we are working very hard to get off the ground. The measure actually becomes law this week. The revenue, there would be marijuana revenue transfers that happen with the next payout from the marijuana account. We have to set up an advisory council and a 24/7 crisis line by February 1. And then a number of things going forward, setting up addiction recovery centers. And the purpose of it is to decriminalize low-level possession charges. So there's much to be worked out in a short period of time. I would expect to see more about it in the governor's budget and as we move forward into the legislative session. So a lot more to come on that. With respect to your specific question, Ebony, there really isn't anything in our concepts that anticipated the passage of Measure 110, to be perfectly honest. I think, Ebony, you yourself can speak to this. We never really talked about the measure with the Governor's Behavioral Health Advisory Council or other advisory councils. So there's a lot to work out there.
Thanks, Annalise. That was, you're right, more than a word.
Sorry.
That's okay.
We're good on time. Other questions?
Just a quick one. This is Brenda. I'm curious, and perhaps this is for conversations yet to come around the kinds of legislative concepts that are going to require a heavier lift for the Oregon Health Policy Board. So maybe not answer this, Jeff, today, but help us understand where we're going to be required to take a deeper dive on some of these. Thanks.
Yeah, thanks for this question. And I'm going to put a pitch in for Steph and Tara and Trilby and Oscar and David, I guess, to maybe make some time at the retreat or after the retreat to talk about that. I think, as you can guess, I have a keen eye for the board's role in all of these pieces, so it will not be hard for us to lift those up and share them with you. Some of them are still placeholder or in flux a bit, so it is, I think, better to do it in a couple weeks or a month or two when some of that dust has settled and it's clear what, you know, if it's going to move forward as is, or it was just placeholder language. The board is often used as a default placeholder place because everyone recognizes that it's a good place to start and end a work product. Yeah, but yes, Brenda, totally happy to return with that information.
That's a fabulous way to wrap up this discussion. Thank you, Jeff. Thank you for the team. We look forward to working with you. Brenda, thanks for the great question, and we look forward to more discussion during our retreat. So take good care. So we will now transition to our ongoing series of community discussions to elevate community voices to understand how COVID-19 has impacted Oregon communities. Today we have the pleasure of hearing from 7 groups that represent the Black, African American, and Marshallese communities to share their experiences. To help us keep on time, we'll hold our questions to the end of the presentations. We'll hear from 4 groups, then have a 10-minute break, hear from the final 3, and then have a discussion section for this section. I'd like to welcome Trilby DeYoung, Deputy Director of Oregon Health Policy and Analytics Division, who will help start us off by giving us an overview and summary of some of the presentations we've heard and introduce this session. Trilby.
Thank you, David. So I just want to give everybody a bit of context because I know we've been hearing these presentations over a number of meetings, and I want to just try to bring it together for us to understand where we started and how we're going to bring a lot of this testimony together for you as board members. So yeah, next slide. Thanks, Michelle. What we did really back in June this was when Director Allen announced the launch of the COVID Response and Recovery Unit, the CREW, to lead our agency's COVID response. And you may remember that up until that point, a lot of the work had been going on in the Public Health Division, and it became clear we really needed a more permanent effort so that Public Health could attend to some other things, not just COVID, but wildfires and many other important work. So the CREW was launched in June, and Director Allen described it as really taking on functions like planning, monitoring data, managing outbreaks, contact tracing, and really importantly, connecting Oregonians with social services as we started to move forward with strategies that were more long-term with the pandemic. And Pat talked about the importance of the CREW keeping equity front and center as they move forward with those strategies. And that really generated a lot of interest among board members. And you all really talked about how much data do we have to help us understand what's going on in historically underserved communities, and will the data give us enough of a story? And it was at that meeting in June when Pat suggested that OHA staff come back to you with a case study so that we could hear maybe more of the narrative, the story behind what's happening in some of our underserved communities. And so in July, the OHA staff came back to you with the story from Ignacio. And this was really one client's experience with COVID as presented by our community partner outreach program. And it was really quite a gripping story that illustrated through real life experiences of one client who had lived through lots of physical and mental health challenges. But it did represent a lot of challenges, barriers, pain experienced by many Oregonians. And the board was prompted, I think, by hearing about Ignacio to solicit more presentations from coordinated care organizations, community-based organizations, providers, with the goal of gaining a better understanding of how communities throughout Oregon have been impacted. And as Chair Bainsberg mentioned, the board was making trips across the state to visit with communities and hear stories and local data. And in many ways, hearing from communities about COVID was something of a substitution for that. And then in August, we can go to the next slide, Michelle, thanks. In August, we heard from a number of groups. And this slide lays out who we heard from at which meeting. This really took place over the next 3 meetings. Virginia Garcia, Health Share, the Columbia Gorge Health Council, All Care came in August to the board. In September, it was Central City Concern, a volunteer from the Family Physician and Mid-Columbia community, and the Oregon Spinal Cord Injury Connection, PDX Disability Justice Collective, and Magic Wheelchair. They all testified in September. And in November, we heard from the Confederated Tribes of Warm Springs. So really, this was very powerful testimony from a lot of different communities that these groups work with. And the purpose behind these listening sessions, again, was to gain a better understanding of community experience and needs. We can go to the next slide, Michelle. This slide gives you a sense of some of the themes that emerged from the testimony. We heard about a lot of different challenges and barriers. What we are going to do as staff is bring together, compile this testimony about barriers and challenges into a health equity report for board members to review at the retreat, which will be early next year. We'll also include in that report the HEC recommendations, the Health Equity Committee's recommendations on equity, and an assessment of the work OHA is currently engaged in to address those recommendations, as well as gaps, places where there is more work to be done. We can go to the next slide, Michelle. And as far as next steps, this health equity update or report that I'm mentioning will be very important for the board to receive, discuss at the retreat. We fully expect that from the retreat, the board will emerge with a set of priorities, and we fully expect that addressing equity concerns will be paramount coming out of that board retreat. It has been paramount for the board over the last 2 years, and as Jeff mentioned earlier, we have the board to thank for OHA's definition of health equity. And what we can anticipate is that as we continue to bring policies to the board, as committees develop policies for the board will be examining, scrutinizing these policies to ensure that they provide sufficient attention to equity. And I'll just give you one brief example, which I think helps illustrate how that happens. We came to the board as a staff with a policy guidelines for addressing mergers and acquisitions that involve CCOs. And what the board said to us is, where's the definition of health equity in these guidelines? Where is the definition of health equity in the rules and the procedures that you're going to be laying out? And we needed to be very explicit, and we needed to be more attentive to framing the process in equity. And so we took those guidelines and rules back, we made some revisions, we came back to the board and really strengthened those components. So I think that kind of work will be ongoing. And of course, community engagement. This board is very interested in hearing from community, as it should be. And I know that we're going to continue to explore opportunities for how we can bring folks in to talk to the board, particularly since regular out-of-area travel is just not possible at this point. It's more important than ever that we create some time to listen. So without anything further from me, I'd like to turn it over to Crystal Marion, OHA's Community Outreach and Engagement Coordinator, who will share a few words. And thank you so much, Crystal, for all the hard work you've done to coordinate these presentations.
Thank you. Thank you very much. Yes, my name is Crystal Marion, and I want to thank the board for allowing us to give oral presentation this morning. There are several people from the African, Black, African American, African immigrant, and refugee community that would like to present today. However, we do have a little switching, so I just want to make sure that you're aware that the names that appear on your agenda might be a little different, just in case. There might be a couple that have changed. So starting us off, though, is Mardisa Hicks, who is the Executive Director with the Children's Community Clinic. And after her, we would have Linda Harris, who is with Maranatha Church. After Linda, Jimmy Dogo, who is with Urkel and Africa House. And then the change would be at that point, Musay Alol, who is with the Somali American Council of Oregon. So I want to make sure that you guys know that order that I've called you. And then we'll come back for the second half. Thank you. Mardisa?
Yes.
Okay, sorry.
Awesome. No, can you see my screen? Hold on one second. Am I sharing with everyone our presentation? Cool. Right. All right, perfect. Well, good morning, everyone. It's so nice to be able to join you this morning. I'm really excited about having the opportunity, or having made for us the opportunity to talk with you this morning. Excuse me, I've got a little tickle. We'll have to work our way through. Excuse me. As Crystal said, I'm Mardisa Hicks. I'm the CEO of Children's Community Clinic. The mission of Children's Community Clinic is to provide high quality and compassionate health care to children from birth through 21 of families who are underserved, regardless of ethnicity or ability to pay. The clinic was birthed out of the African American community in Northeast Portland, specifically to meet the needs of the community that were not being met by the major health concerns. We've continued to do that, and as we've said, we will see any child. Our vision is to ensure that kids who don't have a great place to go have a really awesome place to go at our clinic. And our focus is on wellness and prevention. This is a little look at our statewide households. We'll talk a little bit more about that later, but as you can see, we're focused majorly in the Portland area. We have a lot of families in Damascus, throughout more east of Portland. And we also have a small smattering along the coast and in other communities around. So we reach well outside of the Portland metro area. So we've been invited today to talk with you about 3 topics specifically. 1, COVID-19 pandemic response, 2, health inequities, and then 3, health system support. And I'm going to get right into those. You know, the first question, the COVID-19 pandemic response, we were asked specifically, what are the most significant barriers to your community that your community currently faces in addressing COVID-19? And quite honestly, for our community, for the Black community, African American community specifically, there are three major areas. One is historical bias against the community. The other one is distrust of industry and different standards of care. And then the third is a lack of community-led, community-focused health programs and services. And all of those have really come together to get us where we are today in terms of health in the Black community, the African American community specifically. This is a slide from Improving the Health of African Americans in the U.S., an overdue opportunity for social justice. And I really like referring to this because it really allows us to look at the social determinants of health for our community, the risk factors, the morbidity and mortality, and then the response by health providers and what needs to happen and where they need to focus. It's a really nice conceptual map of health in the African American community. One of the things on here you'll see under risk factors, there's poor nutrition, physical inactivity, obesity, high blood pressure, tobacco smoking, substance abuse. You know, when I look at specifically things like high blood pressure, and we're constantly hearing from providers about, you know, the question wondering why African Americans specifically experience so much high blood pressure. That's one of the things that lets us know that when it comes to our providers understanding who we are, there really isn't much understanding of who we are. And that is something that we really must begin to address. The second question was about health inequities, and we are looking at solutions. The question was specifically, what are the ways your organization in response to the COVID-19 challenges either plans or already prioritizes supports the needs of our Black, Indigenous, and people of color, BIPOC, in their work? And for our clinic, we have a three-pronged approach to the services we provide. One is getting kids healthy, keeping kids healthy, and then teaching children and their families how to keep themselves healthy. In the first prong, getting kids healthy, it's really about making sure that we as a clinic have everything we need to excellently and expertly deal with whatever comes through our front door, that we've got the appropriate personnel, equipment, supplies, materials, philosophy, and attitude to excellently deal with whatever comes our way. That's the first prong. The second prong, keeping kids healthy, is making sure that when we're in the exam room, focusing and making sure that parents and kids understand the importance of keeping up on all of their maintenance activities, that they understand why it's important to get their well child care visits done in a timely fashion, why it's important for them to keep up on their vaccine schedule. And for those families who have to deal with chronic issues, having them understand that it's going to require a little more for them and why, and working with them to make that happen. The second area is education versus medication. You know, we have a real issue in our country that we need to work on around dispensing medications so quickly, right? We need to spend a lot more time on education, especially around nutrition. That's one of those things that we're just going to have to do. It's just sorely needed. And as we look at the data, again, when I had the other map up, the conceptual map, and you look at what the risk factors are, a lot of those could be addressed with better healthcare education. The third area is that we're doing is partnering with other CBOs. And you'll notice that I skipped the third prong because that teaching kids and their families how to keep themselves healthy is really about us getting out of the ivory tower of the clinic and going into our communities where our families are comfortable being and doing, and from that venue, teaching them to keep themselves healthy. Traditionally, we've done several activities with a multitude of other CBOs, whether it's SEI or Friends of the Children or Portland Public Schools or, you know, you name it, we partner with just about everyone. And we've done health fairs with a twist, and they've been awesome. Right now with COVID-19, we're tweaking that a little bit because, you know, we're not able to get out and go to all the different schools and do the traditional activities that we've done. We've begun utilizing our formal and informal avenues and networks in the community to make sure that people have information about COVID-19 in addition to the information about the clinic. And we're doing more and more of that now. We've created what we're calling our community clarion callers. And those are a group, we're creating a group of 25 folks from our community who are community leaders, if you will, formal and informal, who would be willing to create their own group of 10 to 25 folks with whom they would stay in touch, keep informed, and keep updated around COVID-19 issues, real information, where they can go for resources, where they can go for more information, who they might need to call for anything that they need. And making sure that we also utilize them as a feedback loop to hear from the community what their needs are, what needs to change, what needs to stay the same or be, you know, have more of. So we'll be utilizing those types of activities. And, you know, one of the groups that we're calling on and creating clarion callers are retired teachers. There are a multitude of them in our community, and they are phenomenal. They know everybody and have educated just about everyone in the community. So they have hands-on. And in our community, that grapevine is the best way to get information out. So we're taking great advantage of that. The third area is health system support. And that specific question was, what does your community need from OHA, the CCOs, and health providers to better meet their needs, specifically as it pertains to the disproportionate impacts of COVID-19 on your community members? I'm going to really quickly share with you a really kind of graphic story, because I do believe that when we as Americans think about Black Americans, we really don't know what we're talking about. And we need to do a better job of knowing the folks that we're addressing. I want you to just imagine there is a young woman who has been brutally gang raped. And she makes her way to a hospital out in the way back of wherever. And when she gets to that hospital, most of the nurses ignore her. Most of the intake folks ignore her. Someone finally comes to her and asks her what happened. She explains what happened to her. And instead of escorting her to a room, they have her have a seat in the lobby and go to their computer and just start putting in information. It's almost an hour before someone comes to see her. And when they do, the nurse takes her to a room and just tells her, well, I'm going to have you get undressed and a doctor will be in here to see you shortly. Now, mind you, she's just been brutally gang raped. No comfort has been taken for her at all. Finally, about 15 minutes later, a male doctor comes in to see her, tells her to get up on the table. The nurse is there so that he can get a rape kit. Now, I just want you to stop and think about all the trauma that young woman has experienced, and now the additional trauma being heaped up on her by a completely uninformed healthcare system. Where do we do that? Where do we do that? I'm going to suggest that we don't do that anywhere except and unless we're talking about the health care provided to the African American community. That is what it looks like on this side of the fence. That is the experience. As we go throughout our daily lives and experience all of the travesties of wearing this skin, when it comes to our health care, we are required to go in and see those who are the faces behind that travesty. Just want you to consider that. Just consider that. So in terms of what we need is truly a new lens. And I'm glad to see that we're having these conversations, and it's great to do the talk, but I'm going to tell you, this is an inside job. This is an inside job. Yes, we need to have the conversations, but this is an inside job. So more specifically, what do we need? We need you to inform yourselves. Go and find out about who we are. Don't assume that you know anything about who African Americans are. Because if we did, we wouldn't still be getting it so wrong. We have underinformed policy changes, a lack of understanding of whom we're serving, and the impact of the policies that we're creating. We had an experience 2 years ago in which our CCO changed their algorithm for assigning members that decimated not only our panels, but then decimated our clinic financially. And it was right up on the heels of, excuse me, right up on the heels of family care closing. So it was one financial trauma after another. And of course, they weren't thinking about how those changes would impact us, but they definitely did. Second area is having providers trained and certified to work with African American communities. Be humble. Everybody does not know how to work with everybody. And be real. Do we honestly believe that all the Tiki Torch carriers and the, Proud Boys are not members of our staffing? We have to account for that. The third area, and by no means the final, is funding. Supporting additional reimbursement for those organizations who are working with communities of color, BIPOC communities, but especially African American communities, to get them back on track with their health. There are so many other things that have to be dealt with to make that happen. supporting community-led initiatives to address this work. And then based on all of the things that we've talked about, the COVID-19 vaccines, we need to have real conversations with the African American communities about why they should trust that one. Because if you look back in that history, there have been so many times, you know, people will talk about Tuskegee still today, and Henrietta Lake still today, right? And you want to bring a COVID-19 vaccine that's been rushed through all of its processes, and people have heard this, all of the spidey senses go off, right? So in addition, being respectful of the history that people bring with them, and understanding that it's not just about being a Honda. One of my friends who was was a part of one of our institutions of learning for residents here in our area, shared with me the story of African Americans being called Hondas. They were being referred to as Hondas. And I love Honda vehicles, but this was not a good Honda. Honda stood for hypertensive, obese, non-compliant, drug-seeking, and I've forgotten what A meant. I'm sure it's back there. I just, you know, don't want to remember. But having that kind of sentiment coming from residents, can you imagine the kind of care they were providing? So I just really wanted to thank you for having the opportunity to have a few minutes to talk with you about these three areas of COVID-19, pandemic response, health inequities, and then the supports that you could provide to make great changes in the care we're seeing in our community. Thank you so much.
Thank you very much, Mardisa. I appreciate your time and presentation this morning. Next, and the questions are going to be held, or question and answer or discussion, I think, is at the end of the presentations. So next we have Linda Harris from Maranatha Church.
Okay, good morning.
I'm sorry, Miss Linda. Just want to remind everyone we have about 11 minutes each, and I'm supposed to keep track. So please, I just want to make sure everybody knows that.
Okay.
Thank you.
Okay, good morning, and thank you, Crystal, for this invitation to present today. The first question, COVID-19 pandemic response, the most significant barriers our community currently faces in addressing COVID-19 are, okay, in my opinion, there are at least 8 areas that poses barriers in our community at this time. And the first is nonconformity, the failure of some people to adhere to safety practices. There's a pervasive attitude, you can't tell me what to do, like rebellious teenagers. And number 2, access to health care. So A would be insurance coverage. Some people don't have insurance coverage, or the coverage is inadequate. B would be health services. Some elders who don't have internet services, they're unable to have a virtual doctor's appointment via telehealth, you know, which would be a convenience. And some people don't have money to buy their medications, so they ration their pills or insulin. And some people have had very negative experiences with health services, and so they delay seeking care. So C would be timeliness of care. Some people of color wait too late to get medical care based on A and B. And so they do not get needed care until an infection has progressed or their disease is in late stages. And that ranges from, you know, COVID symptoms, oral health care, diabetes, hypertension, heart disease, to cancer, to mental health care. C would be limited income or lack of finances. We know there's job, food, and housing insecurity. People are unable to pay household bills, utilities, rent, mortgages, medications, or even education. And many struggling people are just in survival mode. Some people have lost wages, others have lost employment. 4 would be lack of internet service or faulty internet connectivity and its impact on student learning. When students are learning remotely, the flow of instruction is interrupted if there is unstable internet services. And even when there are no internet issues in the home, there may be other technical glitches. Hang on. Okay, I've seen this happening with my grandchildren. We have a high school senior, a middle schooler, and a kindergartner. And after ongoing computer problems, my kindergartner had to return his laptop to the school so he could be issued another one. I do understand that Portland Public Schools IT department is to work with families who do not have internet service. Okay, so number 5 would be childcare as an issue. So in some households, parents work, so older children have to babysit younger siblings. And during these hours, no parent is present to monitor the older students' work completion. Number 6 would be limited resources for elders. Many elders don't have your smartphones or the internet service, so they can't email or send text messages, and they don't have apps that would make their lives more convenient. Number 7, lack of transportation is a barrier for some people who have relied on other people in the community to transport them. Now with COVID, they are afraid to be in small, confined spaces with others. And 8 is self-isolation. For many, this is a necessity given their pre-existing health conditions. And this isolation, though, can lead to feelings of loneliness and even depression. And people may resist reaching out for help, and they may not know what resources that are available to help them. Also, some people may have been making welfare checks on these people, but due to their age and their own pre-existing conditions, they're not making visits due to COVID. The second question has to do with health inequities and what ways our organization are meeting the needs of people in a community. And I have identified 4 kinds of support that we provide at Maranatha. Number 1 is activism. As a Black organization, we prioritize Black religious people and their families. We have members of our congregations who are active in the community, so we stay educated and help educate others on what's happening in the arenas of health, wealth, education, employment, and politics. And number 2, education and health. We have hosted health seminars on AIDS, heart disease, cancer, kidney disease, diabetes, and hypertension. In September, we celebrate Breast Cancer Month on Pink Sunday. Each November, we host Donut Sabbath, bringing awareness to the congregation about the need for eye, tissue, and organ transplants. And at present, our church has hired a mental health consultant who has been hosting Zoom sessions titled Children, Parents, Families Dealing with COVID-19. We have a gender-based series for men and women titled Trauma and Recovery Empowerment Model. And we've received really profound testimonies from participants about these sessions. Number 3 is volunteerism. We provide our members opportunities to volunteer to serve the community, from food distributions to the homeless, to Christmas toy drives, to neighborhood cleanups. And 4, financial assistance. Our church is providing 2 assistance allocations on December 5th and December 19th. Allocations will be distributed to members of 5 churches. 3 of those churches rent space at our church, and allocations will be distributed to non-church members and to the houseless. Excuse me. Okay, the last question is, Health support system, what does your community need from OHA, CCOs, and health providers to better meet the needs, specifically as it pertains to the disproportionate impacts of COVID-19 on your community members? I can suggest 6 community needs. Number 1, the community needs financial assistance. Making grants available from the OHA so that we can provide assistance to members of our community is critical. And there needs to be grants for relief funds. Number 2, cultural competence. Health professionals need to understand the cultural backgrounds of their patients. Cultural competence is important to healthcare, and it's vital for patients to be able to trust and communicate effectively with their doctors. Number 3, there's a need to get accurate and updated information out to the community on vaccine studies and trials, processes, and procedures. Number 4, messaging. Having, in particular, people of color to do some messaging, as there is a need to trust the healthcare community due to their past failures to do so. Number 5, provide resources on COVID, as well as on the lingering health struggles of COVID survivors. And number 6, the mental wellness of our community members continues to be a great need. Thank you very much.
Well, thank you, Ms. Linda. I appreciate that. You actually did not use all of your time.
Oh, wonderful. Okay.
So next we have Jimmy Dogo from URCO and Africa House.
All right, I'm going to try to follow Linda so that I don't have to use all my time.
Okay. Okay.
My name is Jimmy Dogo. I am the Director of Africa House and Associate Director of URCO. Thank you for this opportunity to present, about what's going on in our refugees and immigrant community, and particularly the African refugee community. So we were giving, 3 questions that we're supposed to answer. So pandemic response, for the African community, I would like to say that even prior to COVID-19, the African immigrant and refugee community were already in public health crisis due to barriers accessing resources. So with the COVID-19, we have seen so many other factors, more, factors that contribute to more health disparity. So for the African refugees, especially for the board, some of you may not know who are those the African refugees. So I will give you a little background of those African refugees. They came here as refugees. Some of them have spent so many years in refugee camp. They're already dealing with a health issue before even they get here. So they come here with already some chronic, disease like high blood pressure, diabetes, and other illness that they carry with them. So the most African, refugees tend to be, essential workers who must work and interact with other people, like delivery driver, grocery store employees, and transit worker. They are disproportionately, low-wage workers who are unable, not afford to not work. So they have to go to work. They don't have the luxury of working from home or shifting, their livelihood to a virtual environment. They are still going to have to deal with, people face-to-face, either at work or even accessing resources. And that creates more risk, of exposure to the virus. The African refugees also, most of them live in overcrowded and multi-generational housing, which, there is no way to isolate in case of, an infection in the household. I've been talking since, the beginning of the pandemic with, Multnomah County Health Department to see how we can help, people who are affected in the household, how to isolate them, and it's really hard. There are some families that don't want to be isolated. All their life they've been living together, and they don't want, one family member to be isolated. So those are the challenges that we're facing. So as I said earlier, most refugees already come, infected with a disease like high blood pressure, diabetic, and all this. So those conditions increase the risk of seriousness of, illness from the COVID. And we have seen so many cases in the community. On top of that, other challenges is the economic and financial challenge due to COVID crisis, that disproportionately affect the African refugees because of, an array of barriers such as program eligibility rules, lack of language access, lack of language access in order to access those federal program or state or local relief program that are out there. Some of those African, they may not even read in their own language. You may be giving them material written in their own native language. They may not be able to read it. They may speak the language, but they may not be able to read it. So that's create, a barrier for the African refugee to access all the available service out there put by some of the, government initiative. But then, we have a community-based organization serving those population, playing the front line, to support those families and fill the gap of, any government assistance out there. So they are the link between those family and the resources. But these, African community-based organizations also face some challenges due to COVID-19 crisis that impose on their own staff, like Africa House. We cannot send staff to family household or home visiting because of the risk. We already have so many staff that got infected at the very beginning because we keep trying to support those families and we keep getting our staff being infected, and that put a risk also in the community. Our staff come from those refugee families living in overcrowded, households. So it creates more, problems, more challenges in our community. And then we also have, we've seen an increase of basic needs such as cash, food, and housing. And then when we talk to many families, the most need is the first, pressing need is cash, followed by food, followed by employment and housing. Another challenge that, but with the African community face is that despite all those challenges, there is also the issue of a public charge. So I don't know if you guys heard about this public charge. There is a law of this administration that if people who are not a citizen getting public services may not become a citizen. So there is still some African refugees that's so scared to go out and getting this assistance because they think that's going to affect their immigration status. It's going to affect, their status of becoming a citizen. So some of them try to not go seek help, even though we try to explain to them that the public charge does not affect those who come here as refugees. But because refugees and immigrants, they're all, living in the same area, in the same apartment. So if one group is affected by this public charge law, the other group think that they will be affected too. So it's create more challenges for our community. So compounding to those challenges, there are continuing exclusion of many African immigrant families from resources and some of those challenges is, how the community-based organization, are receiving assistance from local, state, or federal government in order to help those families. So one of the things that ERCO as well as Africa House, what we did is we stepped in at the very beginning of the pandemic to try to provide support, use our unrestricted fund to help family meet their need until we received, an assistance from the Oregon Health Authority in order to provide some of those emergency services. So again, to answer to the first question, one of the significant barrier is, people living with overcrowd, household, lack of access to language. Just like the speaker before me, we face issue of stable internet connection and technology like Chromebook to a distant learning so that our children can access, education. Most refugees are re-traumatized and isolated because of everything that is going on. They cannot, reach out to their family and all those. And then there's still most refugees mistrust the government and the healthcare institution. So those are also the challenges that it's hard to convince somebody to get out and go get tested or go, seek help. So those African organization, community-based organization are also facing challenge themselves, budget stretching too thin as the need grow, difficulty reaching, family who lack internet and technology and also disrupted, work routine. So the organization community-based organization need more help. Also, for us, the African refugees, the COVID-19 is not just a health crisis or economic crisis, but as a refugee, it's also a protection crisis. So refugees need to be protected by the government who hosts them. Lacking, accessing all those economic, assistance, it creates a protection issue. So we ask for, expanding economic inclusion for the African refugees. Health. The second question was health equity. So what are the way our organization, responds to COVID challenges? So what we did at IRCO and Africa House is that, as I said earlier, for Africa House, we took our own, 45,000 and restricting fund in order to distribute to a family who are dire need of support. We also gave, about 20 small business organization cash assistance in order to keep their door open. We also provide rental, utility, gift card, and PPE assistance. We work with DHS and Oregon Employment Department to allow us to do employment benefit, through our program. So that's helped a lot of refugees who cannot access, employment services. We were able to providing them with employment service. We provide also service for, and not only assisting with an employment claim, but helping preschool for family in Washington County. We did a telephone interpretation, provide technology like Chromebook, hotspot for refugee family in need of distance learning. And then we partner with Multnomah County Department to do on-site IRCO weekly COVID testing and help people with self-advocacy. Lastly, number 3, health system support. What we need, from OHA and CCO. We need more rigorous assessment of CBO prior to awarding them more pass-through federal fund to prioritize, some of the agency proving track record. So, for instance, you have a Somali, for instance. Somali are the largest African community here in the state of Oregon, but they receive the less funding to provide service to the community, while the small African community receive more funding. So it's create problem in the community, especially for the leader in the community, in the Somali community, who receive a small funding and cannot provide service to more people in the community who are in need. So it's create tension within the community, why some of them receive, why didn't receive. So I don't know how, the Oregon Health Authority distribute the fund in order to help, but if there is an opportunity, again, I wish that you guys look at the size of the population that you're providing funding. We need funding, and more funding in order to continue to provide health. We need more testing for our community to get, and also to get the COVID result faster. And then flexibility in contract rules, such as, impacting gift card and receipt. Small business technical assistance. We need a lot of technical assistance for our African small businesses. We need more PPE, and including things like thermometers. We need public education through our community healthcare worker, and then to educating the community in case of the potential vaccine. Africa House has worked with Multnomah County Community Capacitation to create a curriculum for community healthcare worker training. So we have a trainer in the community. We have culturally specific curriculum. We train 50 African community healthcare workers from different community, and Oregon Health Authority should use those people to educate our community if there is a vaccine, because African refugees tend to not trust the government. So most of the time when they come here, they don't want to take immunization and all that. So to conclude, there is an opportunity for the Oregon Health Authority as well as elected officials to change the social and public health landscape. There is a need for a real radical change to actually actualize equal opportunity for all of us in Oregon. So Oregon Health Authority and official should address, the social determinant of health disparity. So again, for the African refugees and African community, we feel like we are locked down and we are left behind. We need more help. Thank you so much.
Jimmy, thank you very much for your presentation. I appreciate that. I don't want to take up time talking, so I'm going to ask if Musei Alala is on. I know he was having difficulty getting on.
I am on, thank you.
Perfect, thank you very much. So at this time, we will be hearing from Musei from the Somali American Council of Oregon.
Thank you very much for the presentation, and I appreciate it for giving me the opportunity to talk on this today. Our organization that was actually created in 2011 because that's when we found out there was nobody really out there for the community. Of course, everybody comes into this country and you became a refugee for a while, but you moved on and you become part of the fabric of America. There's a process in the middle. I appreciate the way that some of the challenges that this community is facing. Ms. Hicks and Ms. Harris have actually eloquently talked about it, because first and foremost, we're African American for the appearances of Black. But also we have, on top of that, we have linguistic challenges, which are language challenges. We are pretty much have no understanding what the racism and how it works and how it impacts our lives, other than just negatively, and don't even know how to prevent or even protect yourself because you might not have the language to do that. What we find out as we going on through this, we found out the common barriers that coming up from OHA was a lack of knowledge of the intentional outreach done by to the Somali community, and I think Jimmy explained to that as far as the community that we actually serve, according to the study done by PSU on Coalition Community Color. In 2015 study of the African youth, 68% of the study was actually for Somali community. So a lot of people don't even know how big and how large this community is. For the Portland Public School, the last count they had about was third most spoken language as of 2016. You have to understand, 2017 members of this community were banned to come to this country, so that kind of reduced the representation at the school district level or any other place. But nevertheless, it was a huge population that was not connected by and it's not only the OHA, but same thing happened from Multnomah County. It happened from the city of Portland to a certain extent. And one of the questions that actually, one of the things that was mentioned was Multnomah County Health, called Mid-County, which is less than a mile away from our office. He didn't even know we existed. He didn't even know we're here. But also one of the challenges that we have is a lack of sufficient interpretive material. Like OHA and other organizations, they have material flyers that were actually, some came straight out of Google Translate. Another challenge that we have is what I call is right now, and he mentioned that it's the way OHA was approaching. I think Jimmy did a good job. Thank you. There's so many organizations, and something that I call the COVID CBOs. Basically, even within Somali community, there were 4 or 5 of them were created after during the COVID, and even 2 of them were made in August and September. And nevertheless, by moving funding to those organizations, what they're going to do is they're going to deplete resources that were given out in the name of Somali community. Just kind of give you one of the things that are going on. So we need to understand who is the African community, which is literally the Black African American community at the end, which kind of in process. I always tell people it's a caterpillar eventually going to be becoming the butterfly. When you compare the African to the African American community, it's one of the same. It's just we have a different stages and different challenges, and of course you're not able to fly or being able to navigate through the system. And that is actually the one thing that Jimmy mentioned is actually disproportional distribution of funding was amazing. Especially we did not get given the population that we serve, we did not get what we get. Just City of Portland finally got it, especially when we reach out to the challenges that were mentioned both in the African community and African American community. The digital equity, we didn't. A lot of kids don't even go to school system because they don't have mothers or parents that can help set up. So we work with a project that's called Digital Divide, and they realized that it gave us almost enough for 1,550 families. That's households, and that's just by share, just our share. They couldn't suffice our demand of 3,000 plus families. So this just kind of give you in a nutshell where the challenges are and what we expect to OHA. I think it was OHA equity person that told me the best answer when I said, I am sorry, I feel like we didn't reach out to you in time. We should have come to you. The answer was, we should be, as a government, our responsibility to find out who you are. We should be able to search it, go to online, Google it, find out, and get to know who you are in this community that we serve. Because as a government official, it's your responsibility to share equitably to every community that you serve. So just going back to when COVID-19 started, what was our reaction was that when there was no jobs, majority of the population, they're actually low paid, but the majority of the Somali community, overwhelming majority of them work into hospitality business, cab business, hotels and whatnot, which literally dried out overnight. And the challenge is that we were glad that officials decided that we're not gonna cut you off electricity, we're not gonna kick you out of your homes. But we thought that what was the most important thing for any family to do that was very much giving food. So we started with 40 boxes. I remember that when we called like the Sunshine Division and say, we need help, and they only bring 40 boxes for the first week. But as we connect with others, we graduated to 3,000 to 4,000 families a month. And that came out through the community getting galvanized and the spirit of the community. We're a lot of volunteers. We didn't have to begin with, being a small organization that was started in 2017, the office that we opened here due to what happened nationally, people get spooked and they need to have a center. It was overwhelming. It still is overwhelming what we're trying to do. But we also, whatever we have, not only is limited to the Somali community, but other African community. We have a lot of members, almost I would say 30% of people that we serve right now are from Ethiopian community. Also, it has a large presence in the state. They came here in the 70s, and most of them were kind of moved on from refugee to what's considered almost mainstream, but nevertheless, they also facing hardship. But we also share our resources to other refugee community, mainly Iraqi and also Syrian refugees. And whoever else walks in, this is open source for everybody. We share with anybody that walks to our doors and share whatever we have. Food is a must. It's a very important thing that everybody should have. And especially, it's hard time to see people starving under the shadow of the planet, which is America is. So we need, as far as the needs, I can mention it's important that we have to have a equity training, and also I'm going back to my notes as well. We need to understand, as far as OHA or any other authority, I think City of Portland figured that out. Multnomah County is in the process to do that, and what it took is to invite health officials to a park and basically invite the 4 imams, the mosques run in Multnomah, Portland's metro area, run by by Somali and operated by Somali community, and basically said, this is our center. Like any Black community, that anybody goes, almost anybody goes to a church, and in the Muslim communities also, Somali communities also, everybody connect to the mosque. The mosque itself creates opportunity to the imams and elders, and also we can give the information to the community, trust information, because if you're just gonna send an email, a flyer, or any other ways to do that, like Jimmy was talking earlier, the people don't have a trust of the community. So it has to come from religion elder. It has to come from the leaders, primarily women and men in the community, in order to understand and help gain that trust. So we're talking about vaccination. It's very important. But nevertheless, you can't just do your traditional way. We're going to send email and flyers and expect people to come into the testing center where they're going to have the vaccinations, especially with all this. So we have ways to do that. WhatsApp is what most common way to reach out to our community. It's not by email. It's not by phone calls. It's not other means. But they have WhatsApp groups. Each mosques have their own WhatsApp system, so we can just easily within minutes we can reach out to the community with information like that. We do have a staff, thanks to the funding that we get from OHA. We're able to actually hire people that are here and help the food distribution. We do at least 2 days a week, but sometimes we go third, depending on how much, especially toward the end of the month when the people's needs of food increases. But nevertheless, it's so that is what I want to say with you. I think I want to remind you, it's your responsibility to do it right. To help the community. In the past, if we don't get the grants, it would have been like, okay, we don't have these resources. But this time, if we don't get the resources that we need, it could be somebody's health, it could be somebody's life. And you have to understand that the study that was actually reached out to me over 2 months ago, Somali community and Congolese were the highest population of COVID-19 cases, both in Manama County and statewide. I believe was in the level of 7 to 8%. To 3% subsequently, both the state level and federal level, which is kind of close to the Black community nationwide. So with that say, I thank you very much for your time, and I appreciate it for giving the opportunity to speak and present the voices of this community. Thank you very much.
Thank you, Muse. I appreciate your presentation so much. We have a break coming up, and I know that it's supposed to be at 10:30, but I don't want to start any other presentations because I don't want to cut into the break time. So if at this time I can just pause until 10:40, is that what we do? Okay.
Thank you so much, Crystal. Yeah, and thank you for the presenters. I look forward to hearing more. We will reconvene at 10:40 prompt. Thank you so much. We're continuing with our community group presentations, being very well managed. Thank you by Crystal, Marion. Appreciate your contributions and look forward to the upcoming presentations. I hand it over to you, Crystal.
Thank you, sir. So next we have Kairos PDX, who will be speaking today, and I believe, James, are you on? Kairos PDX? Okay, maybe he is not back from break. I did speak with him. Oh, he's there. Are you ready to go, sir? You're still muted.
Sorry.
Okay.
Sorry, Crystal. Yes, I am.
Okay, and
so,
just want to keep you guys with
first
the time.
of all,
10 minutes. Yes. Okay. Just want to keep with the time. That's all. Just remind you of the timing. That's all.
yeah, there is a, I think. Yeah, no problem. I was just also thinking that there was an internet problem. Can you hear me okay?
I can hear you now. You were frozen just for a moment, but yes, we can hear you and see you now. Yeah.
Okay, great. So first of all, my name is James Kelly. I'm the Fund Development Manager at Kairos PDX. Lee Ladd sends her regrets of not being able to do this presentation today, so you guys will get my ugly mug instead. Kairos was founded in 2012 by a group of predominantly African-American educators and policymakers. The Portland Public Schools systematically failed to adequately serve historically marginalized and disenfranchised communities. Children have succeeded despite systemic barriers. However, according to data, there are few that's doing so. This, a lack of service is directly toward African Americans in grades K through 3 is particularly has been identified and achievement gaps has widened. Kairos was founded in response to this need. In doing so, created a unique and has taken actions to create an educational model that leads with love and is built on neuroscience on how kids learn. We are initiating a movement to push the rehumanization of children to the center of education narrative and experience. We serve over 230 children K through 5th grade. Let me just say, we want to thank OHA for their commitment in investing in supporting the Black community. We are at a critical juncture.
Oh, are you the? Okay.
Can I go?
Yes. I can hear you. Can you hear me? James?
Okay.
James, if you're having trouble, maybe to turn
we're
on
at a critical junction of looking at protect. You can't. You can't hear me?
I can hear
I
you
can
now.
hear you.
I can hear you now.
Try turning off your video. That might help, and we'd be able to hear you consistently.
Can you hear me now?
Yes.
Okay, great. Sorry about that. Let's say that we are at a critical junction that we're looking at protecting children and families from the COVID crisis and mitigating learning losses from companies and communities where children are disproportionately impacted. We need to support families and educational organizations to be fluid is a critical.
James, it was suggested that maybe if you turn off your camera, then the connection for audio may work better. Okay. I'm thinking maybe we have lost James. So I don't want to delay the time. And when he comes back, maybe we can. So James, what I'm going to do you want to turn off your camera and present? Then maybe the audio would work better. Let's try that.
Sure. Can you hear me?
Yes. Yes.
I'll try. Okay, good. Okay. Access to devices and more technological infrastructure is what's critical, as well as the air infiltration system and the PPE equipment to ensure that our children stay healthy when they are back at site. New computers are speed matters. This is a critical look at equity in our educational system. And the last thing is we are looking at a need for a full-time school nurse to help make sure that we keep our children separated
So James, if you can hear me, I'm going to ask if you could go off and call in, and we might be able to hear you better. To save time, I'm going to go ahead and have our next presenter start, and then you can actually, because what you have to say, I'm sure, is very important, and I don't want to miss it. So if you hear me, please call in, and we will have Julia Mines go ahead and present at this time. Julia is from Miracles Club. Julia, are you here?
Yes, I am. Can you hear me?
I can hear you now. Yes.
Okay. I'm also having internet problems. They're working on our internet today, so I've been kicked off a few times. I'm trying to get it right.
Would you like to call in and present that way?
What's the number to call in on?
It is the link that I sent that you sent for this meeting. You would dial one of those numbers.
Okay. I will call right back in. Okay.
Thank you. Thank you. So, Mr. Bangsberg, what should I do at this point?
You're doing a great job. Thank you.
I can, I guess, speak to the fact that the work that I'm doing with the community, I'm enjoying it immensely. And these organizations, I know that they are busy and they have Julia, you're still there. Julia? Okay. So, James, are you ready to go ahead?
And Michelle,
Sure.
Make sure that people have the right phone number to call in.
I will resend it.
Yeah. I think we're ready. Go.
Sure. The last thing, I hope everybody can hear me okay, Crystal, is that we're asking for a full-time nurse to help keep well-separated sick kids from COVID kids and other illnesses. This is a flu season that's coming up, and that we want to separate flu kids versus COVID-19 kids from other kids who are just sick. Existing condition. Last, we want to track data regarding age, incidence, pre-existing conditions, flus, and COVID-19. This will allow us to promote health education.
So James and Julia, if you can hear me, I just sent the link, the phone number that you can do the one tap, and you can, so the video maybe is not working well. If you want to go ahead and hang up and call in to that number that I just sent to you on your email.
Okay, I would do that.
Okay.
Crystal, could I make a quick suggestion?
Yes.
Maybe while we're waiting for folks to see if they can get a good connection in, if you could take just a couple of minutes and talk sort of more programmatically about the work that you and your group are doing to address some of the things we've been hearing about in these presentations.
Yes, and I will not make the mistake of calling you sir. So I work with the Community Partner Outreach Program, and I've been in this position since August, but working with the community has always been something that, as just a person, that's just who I am. And so within CPOP, my work is to build relationships and to help to amplify the voices of the Black, the African American, the African immigrant and refugee communities. And one of the things that Musée had said, which I totally echo, is the fact that it is important for us to go and find the organizations, and that's exactly what I sought out to do. And I started with those that I knew because I'm from the community, and then worked from there. And it has grown from about the 45 that I had started with to about 70 organizations and individuals, some that are not necessarily directly tied to a particular organization, just community members at large. And just being able to talk to, and some of the work, I call them community check-ins, but pretty much it's just an opportunity for me to be able to listen to the voices of the community. And the meetings are directly based on what they want to talk about. I reach out to the faith community because I believe that again, I think I heard that and echo what Musée said in regards to a lot of people, they go to the churches, they go to their different faith institutions to be able to, well, I know why I go, but just to be able to be heard, to be able to have that sense of wellness and health and mental stability. And so in reaching out to all of these various organizations, I have found that there has been a common thread. In the beginning, I was trying to reach out and do meetings for the African community and meetings for the African American community. And I was hearing a lot of what were some overarching themes. And yes, we have a lot of things that are addressed in the way in which we do things a little differently, but we are all in need of, and I don't want to get emotional because I do when I sometimes have these group meetings, but we all have needs that need to be addressed. There are issues in the communities in which we want to make sure that, for instances like this, being able to elevate this information to as to what's going on in the community. And one thing I want to say is I appreciate, because I know that all the organizations are really busy. Those of you that are grantees are trying to continue doing the work that you're doing to make sure that you're expending the money, you're working with the families, you're making sure that the needs are being met. So I know you take off the time, and I want to say how much I appreciate you for taking the time to do the presentations this morning. I didn't have to bend arms. I appreciate that. But it's the work I find. I actually say to myself sometimes, and this is something I say to my family, I said, I get paid to do work that I enjoy. I actually enjoy working with the community. Even during the midst of COVID, I've had a couple of in-person, outdoor, socially distanced meetings because the community member wanted my presence and I did not want to say no. So my feeling is that the work that we're doing is meeting the community where they are. And it's not necessarily on our terms, it's what do you need from me? And being able to sit back and then listen to that and bring that information up to the policymakers, to the directors, to the DHS, everyone who needs to know, so that there's a connection. And I'm hoping that my work is helping to bridge some of the gaps.
Thank you, Crystal.
Thank you. So is that Julia, are you on? Or
yes, can you hear me?
Yes, we can.
That's better.
Okay, great. I was wondering. It's all just overwhelming this afternoon. So my name is Julia Mines. I'm from the Miracles Club. And the Miracles Club has been around for 26 years. It is a clean and sober club that rents space to self-help meetings, community events, and any private events that people want to rent the club for. Like I said, we've been around for 26 years, basically catering to the African American recovering community. So I just want to jump into the questions about that I was sent. So one of them is, what are the most significant barriers your community currently faces in addressing COVID? I think for the African American recovering community, not just recovering, but the African American community itself, the lack of care for our community, and I've heard that over and over in the other presenters, but it's real, that there's a lack of care, there's a lack of understanding about the African American community, then there's a lack of understanding of the African American recovering community. The bias that happens for African Americans in this city, it kind of tailors to, you know, the trauma that the historical and generational trauma that African Americans have faced, that it carries forward into, which is now 2020, going on to be 2021. That bias happens, it's not invisible, it may not be seen outright, but we feel it. People of color, people with skin color different than others, we feel it all the time. We were some of the last to even be offered protective equipment. Miracles Club. And yet, what I've done as the ED here is keep the doors open, because everybody doesn't understand Zoom or how to get on Zoom. Everybody doesn't have a computer. Everybody doesn't have a phone where they actually know how to access those things. So I keep the doors open for in-person meetings, but we adhere to the safety measures to keep ourselves safe. And then we have the African American community itself, with the biases that if we join together, that COVID is going to run rampant in our club, which it hasn't. We've had one outbreak since we've been here, since these doors have been open, and we shut the club down for 2 weeks and properly cleaned and made sure that everything was ready to open back up. We didn't have to do that, but we did, because I want to keep our community safe. I have a little frog in my throat, so you guys have to excuse me. It jumps up every now and then. And so the understanding that recovery is real, and that recovery is relationship building. We have to keep our doors open because people isolate, and since this COVID pandemic has hit, we've lost a lot of folks to relapse and death because they've chose to go back to using drugs rather than reach out. And when you're in some of those spaces in your head, it's easier to get in your head than to reach out or pick up a phone or call somebody or go see somebody or go to a meeting, which is in this city right now, there's a lack of in-person meetings. So then I want to go on to what are the ways your organization, in response to the COVID-19 challenges, either plans or already prioritizes or supports the needs of Black, Indigenous, and people of color in their work. Well, what we do is, what we have done is we've reached out to all agencies, especially Multnomah County and the state, that are providing monetary supports to get that into the club so that our peers and our clients and everybody is aware, and that we're passing that information and that support out to them. There's also trying to consistently find out where they're being COVID tested, where the COVID testing is being done, what it takes to get it done, and we've ran into a few roadblocks in that area trying to find out where's the COVID testing happening. Now it's opening up now, but in the first 6 months, it was almost unheard of unless you had symptoms themselves. We reach out to our folks, we support them, we're bringing them in, we're reaching for all the resources available out there for the folks in the in the African American recovering community and African community at large. The health supports, what we understand is there's a lack of understanding of traumatic health history for the African Americans, what has been done to us. So we have some people that aren't going to get tested, because it's been out on the internet that if you get tested, they're actually giving you the pandemic. There's a lack of education, and there's a need for education rather than the lack of stigmatizing the African American community. We have other older folks out there that are in recovery and not just in recovery, but just older folks that are isolating in their homes because they're so afraid to get this virus. I had a couple older members of the club. They refused to come out of their home because of this pandemic, and they have some health issues, so they're just not reaching out for the help that they need. There's a failure for safety practices. For instance, the Miracles Club has given out gift cards on 2 different occasions. And the people that we cater to, I've asked that when they come to get in line that they wear face masks, that they keep social distance 6 feet, that they have hand sanitizer or use the hand sanitizer we provide for them, and they just refuse. They want to be in line. They don't. It feels like, I'm not saying they don't want to, but it feels like, even after saying it over and over and over again, that because that money is available, they want to make sure that they're in line to get it, and they will not practice the social distancing, or they'll have a mask on and it won't be on properly, those kind of things. And at one point, I've had to shut it down, the lines down twice because of that. We got to get some distance. We got to get some uniformity here. Like I've told them, I don't want COVID, and I'm sure you don't want to walk away with it either, so please practice your social distancing. And it took a lot for that to happen. The lack of electronics for folks to get connected with treatment, with peer services, with supports, that is happening. And not having the supports to give that kind of support to the folks. So what does your community need from OHA, CCOs, and health providers to better meet their needs, specifically as it pertains to disappropriate impacts in COVID-19 on your community members? We need all the above. We need whatever we can do. We have a couple outreach people that are going out and reaching out to folks, but I have to really adhere to them, tell them that they need to keep themselves safe first. But we're reaching out, we're applying for the grants that are available to help our folks. And yeah, that's our question. Hello?
Yes,
Hello?
yes, Ms.
Okay.
Ms. Julia, we're going to have questions at the end. We have 2 more presenters.
Okay,
So
there you go.
Okay, thank you, ma'am. Appreciate it very much. Our next presenter, let's see if James was able to get back on. James Kelly?
I'm here.
Okay. You can go ahead.
Okay, yeah, so my last presentation was that we're definitely in need of a full-time nurse, particularly when the kids come back to to school to help keep the sick kids from the COVID kids and any other illness. Secondly, this is flu season that's coming up, and we want to separate kids with flu versus the COVID kids from other kids getting sick. 3, we want to address kids with existing conditions. 4, we want to track data regarding age, incidence, pre-existing conditions, flu, and COVID. This nurse will help us promote health education. It would help us respond to emergencies and helping students with chronic conditions such as asthma and diabetes. And they can act as a liaison for mental health, substance abuse, and family counseling. Thank you.
Thank you, James, and I appreciate you guys working through that for the technical difficulties. Thank you.
No problem.
Okay. Our last presenter is Jess Gasper from the Marshallese Community Association. Jess, are you on? Jess? Okay, then I think if Jess Gasper is not on, then I will turn it back over to you, Mr. Bangsberg.
Thank you, Crystal Marion, for a great discussion, managing the internet challenge as well. I really appreciate you leading this discussion. Also want to thank Trilby DeYoung for the introductory comments to sort of put this in perspective as and summarize some of the conversations we've had prior to this. You know, I really appreciate the diversity of perspectives that we've heard today. And also in each group, each presenter had a different perspective. You know, overlapping challenges emerged. And these overlapping challenges, you know, reinforces or reminds us of the challenges we had even before 2020, before we had COVID. And COVID comes at a time where there's these pre-existing challenges that include current historical trauma, financial hardship, access to healthcare, behavioral health challenges, should have made equity our #1 priority pre-COVID. And that as we see the impacts of COVID in terms of its differential impact on Black, Indigenous, and other communities of color, that it is exacerbating these inequities in profound ways. That really, you know, this should have been our first priority before COVID, and now it's even more important. And how do we overcome this, which is, I think we have some time to discuss and to address today. One of the things I've heard is overcoming or developing new level cultural competency to get out of the hospital, to get out of the clinic, to get out of our university, state, or county office buildings to understand and see what is happening and to reverse these equities. So I would like to, I have a few questions, but I'd like to invite the board members to comment in terms of what reoccurring themes they've heard, what questions do they have for our presenters, and how we can take this information to address issues related to equity.
So this is Ebony. I just want to appreciate the range of perspective and commitment and willingness to come forward and share all of your experiences, your recommendations, and your concerns. And, you know, a couple of questions that I have, you know, are specific to behavioral health. And I know that there's challenges when it comes to folks either not having the right levels of internet connectivity or devices to participate in, let's say, behavioral health services. You know, I know that, you know, locally in the community, there are places where services are being offered in person for those that want to take advantage of that. But then I know that folks are concerned about not wanting to step outside their homes to risk getting exposed. And so I guess my question is, you know, do you all have recommendations on how to increase the awareness and to increase the utilization of behavioral health services, both substance use and mental health services in the Black community?
So Ebony, we just heard from Jess. Jess Casper is back, has joined us. So if we could hold that question here from Jess and then come back to a question for the group.
Yes, absolutely.
Right. Jess, are you here?
Yeah, I am here. I'm happy to be here. Good morning, everybody. And I was told that I was gonna talk about some Marshallese experiences with COVID. Is that correct, Chair?
Yes.
Perfect. So I'll go ahead and talk about these testimonies that people have shared with us here at OMCA, Oregon Marshallese. My name is Jess, by the way. I'm the president and executive director for Oregon Marshallese Community Oregon Marshallese Community Associations. These two accounts of experiences with COVID-19 in the Marshallese community are written in first person. They are not actual people. The stories they tell, though, are made out of the real experiences that are common in the Oregon Marshallese community. Allegiant Gideon came to Oregon in 2012 from the Marshall Islands. One brother and one sister of his had already settled in Monmouth and in Oregon, Tigard. I was so ignorant when I got here. Everybody's so rich in America, right? And there is plenty of room. I mean, it's not a small island like where I'm from. So my brother was driving me from the airport, and I'm looking around and I thought, I can live wherever I want. I'll just pick a house and we'll just take that one. It turned out a little differently though. 3 of my kids were born here. So they're a citizen. We live in an apartment complex in Salem, right off of Lancaster Drive. A lot of times the new families would come from the Marshall Islands and they'll need a place to stay. So we keep a spare room. I don't know how many people have stayed with us. Sometimes in a few weeks, sometimes a couple of months, probably, I lost count, maybe 100. Counting the kids and everybody. I've been working 2 jobs most of the time. It's all right. My wife looks after the kids or some of the older folks that have health issues. The last one was in a factory. The last job that I had was in a factory as a security guard. In March, an uncle of mine who was living in Arkansas came down with COVID. He left work on Thursday, took Friday off, and by Saturday, he was pretty sick. He went to the hospital on Saturday night. He was having trouble breathing. On Sunday, he died. I watched all of this on social media. It was like it happened right in front of me. The factories in Springdale, Arkansas closed down. A lot of Marshallese people were really scared. My dad and my wife's parents live in Salem too. My in-laws are in the same complex where I live. They all have diabetes. We asked them not to come over to our apartment, and we told the kids not to visit them either. This was pretty hard on everybody. I had a problem with my truck, and I didn't want to pay to get it fixed because that was most of the money that we had. When I got sick, I got called up both the jobs that I had, and I told them that I couldn't come. A place where I worked as a security guard said that they would hold my job. But I got a letter 3 days later from the factory saying that they laid me off. I had been sleeping in the garage that belongs to my wife's parents. My wife's kid would bring me food every day. I got better after 10 days of isolation. I went back to the security job and I found another job during the day. We're still low on money. We're behind on rent, and the landlord kept asking for money. When my family finally got the rent assistance from OMCA, as well as payments for lost wages, we were able to repay what we owe. It's still pretty uncomfortable with the kids at home during school and our elders living apart by themselves. I am really happy for this help from our community and from the state of Oregon. When we get these requests for assistance from our community members, when we first started to see their bills, we would see $1,000, sometimes $2,000 on electric bills. And at first we were just looking at them, kind of shocked. And then it became a norm. I think these last couple of months, we've seen over 300 people seeking assistance. and all of them are behind on their bills. 4 to 5 months. And excuse me, the money, it's not just about the money. I mean, people are about to get kicked out. Their lights are about to get shut off because they were living paycheck to paycheck. And when COVID hit, it was really tough on everybody. So I'm sorry, that's it for now. Thank you, Chair.
Oh, sorry, I was on mute. Thank you, Mr. Gasper, for sharing that testimonial and perspective. Ebony, let's go back to you. You were making some comments and about you're in the middle of a question.
Yeah, I just want to, thank you for, Jess, what you just shared, because the experience and the pain is real. And, what I recognize is that especially, when we're thinking about, our non-white communities, when we come to the table and when we open up and we share the pain, it's with hope. And so I just, am honored that everyone is willing to come and share. And I know that, I'm committed within my role to demonstrate a meaningful response to, how do we make decisions that truly do improve the outcomes of our communities. And I just want to just hold space and thank you for being willing to share your stories. And with that, recognize the pain because it's real. So my question was just wanting to hear some feedback around if you all had any recommendations of how do we increase folks' awareness of behavioral health services that are out there. I know, and then the other question is, and then how do we increase folks' willingness to consider utilizing the services once they are informed of what's out there?
Is that open mic? I'm sorry.
Go ahead.
Yes, this is Jimmy Dogo from Africa House again. One of the challenge when it's come to mental health with the African in general and particularly the refugees, it's a taboo. So people are, in many African languages, we don't even have a word for mental health. If you displaying some depression, mental health issue, post-traumatic disorder, and all those, either you are weak or you just crazy. So many African who, African refugee who lived in refugee camp or who witnessed atrocity during the war in their home country, they came here with post-traumatic disorder. They're displaying those symptoms of mental health, but yet it's hard for them to seek help because they don't want, the community to know that they're having mental health problem. They don't want the community to know that they're crazy. So the only way, because they already came here mistrusting the government. They don't trust the government from their home country, so they come here, they don't trust the government. They don't trust any system. So in order for those people to access, services, we have to build the trust. We have to work with our community healthcare worker, and particularly we will have to work with religious leaders. Like Musa Olo said earlier, the imam play a very important role in our community when it's come to talking to people, when it's come to people going through depression, challenges, domestic violence, and all those. So we have to use the community intermediary to be, helping those families to play the role an intermediary between the service providers and the patients or people who need care. But in order for those people, to trust the system, in order for those people to come forward in order to seek services, the imam need to intervene to talk to them. The religious leader or the community leader need to help them, because in the refugee camp, some of those African refugees have lived in refugee camp for more than 45 years. Burundian refugees live in a refugee camp in Tanzania since 1972. So people were born in refugee camp, grew up in refugee camp, all their life, they get married and all those. They went through a lot of trauma. So they trust people who look like them, speak their language, and people who play the role of the leadership in their community. So in order to help, it's not like a mainstream people. Somebody will just walk in the office and then he start asking questions and then gonna give you a straight answer. It doesn't work this way in our community. You have to go through our community-based organization, religious-based organization, and also people who are trained, professional trained people in our community who can make the link and referral of those services and be there to support those people. It's just too hard for somebody that does not speak English, somebody that comes from a society where there are a lot of support, community support and all those, and then they come here, they're completely isolated, living in their apartment and just the children and the spouses and all those. So we need to create this community support that will help those families. It's not like the American culture where the individualism. For us, we all come together when something's happening to somebody. So it's okay for us to support this person, to help this person to go seek help. That's why the organization, community-based and religious-based organization play a key role for the service provider to reach out to us and how to work with those people. I will give you an example. This is not just an African, but refugee in general. A few years ago, Miloma County started talking about, emergency preparedness, and then they invite a lot of Chinese community for a meeting at the Irko gym without using community intermediary. After the presentation, most of the refugees left Portland because they say that they think that the earthquake is going to happen tomorrow or the next day. So about 80 to 85% of those families left. That's because the information was wrongly, disseminated in the community without going through the community leader and the intermediary and all that. So again, please, if you want to help our community, don't hesitate to reach out to us, and we will bring you people in the community who are leaders, play a key role so that our people are not left behind. Thank you.
Can I quickly add something, please? I think Jimmy said it for the African community that I was speaking on it. It's nice to actually get to see you, Ms. Clark. One of the challenges that we have is even have to deal with a family recently that their son had being diagnosed with schizophrenia, which also having a drug problem as well, which kind of adds up to the problems. And the family had no idea what that word is. I had to literally try to explain them what that does and how it's basically the symptoms, which they know the symptoms, but they don't know the word on it. And we have this is actually several cases of schizophrenia in the community that also drugs have been added. I think I talked to Jason Renaud about some of the issue, but I'll be glad to connect with you after this and create some kind of system. I'm a member of board member for Lions for Lives for suicide prevention also, which is in drug use, which is also another problem that especially the young refugee, the one that were born here, are actually part of American fabric that are actually soon developing these kind of problems. So thank you very much.
Thank you. Other questions, comments from the board?
I have a comment.
Yes, please.
I'm Tanya from Black Men's Health Oregon. I think that in order to, there's many ways to bring information to the community, and just like Mr. Dogo stated, sometimes it's detrimental how it's given. I think normalizing the conversation about mental health in the community and using our, I don't know, I don't want to be offensive, but training for us, by us, using, like he said, utilizing the people in the community. I think that people can get, I'm trying to figure out how to say it. I have a lot of thoughts on my mind, but one of the things I think would be training the community members, giving them the supports they need. A lot of times, a lot of the companies, businesses, I should say, the state, other people, you turn your computer off at 6 and you go home. Us people who work in the community, most of us live in the community, and our work continues because we are living in the with people, around people who need services. And so training people who are in their own community to best serve them would make more sense. Normalizing the conversation about mental health, normalizing, everyone's traumatized by COVID, right? Everybody's traumatized by COVID. It's affected everyone. Use it, use that. Make a video, explain to people in their own language, this is a trauma that has affected everybody. Try to find ways around normalizing the conversation so they don't think it's, someone saying, well, just Black people are crazy, or just Africans, or just refugees because you went through this or that. But normalizing it and saying across the board, we have had, everyone's been traumatized at this time, and use that as a way to bring the other information in. You know what I mean? Like, find different ways. We're using videos. We have someone that creates videos. We have interpreters. We have ASL, and we're using different ways to think outside the box to normalize the conversation, and keep running the ads, keep running the Facebook ads, keep sending out the emails and making pamphlets and those type of things. When you start seeing things over and over again, it becomes normal. When you keep talking about it, it becomes normal. And so that's my 2 cents. Just, try to normalize the conversation, but most of all, utilize the people that are in the community. That's their community. Give them funds. Give them funds to be able to support the people to do the job. Give them training. There's a lot of trainings that the state has. As a person who started a nonprofit, I was never able to get into this position to train anyone. I wanted to train people that look like me, people in my community, but the roadblocks were, well, the training is $2,000. Well, we don't have any scholarships. You guys have money. Make a space for people, Mr. Dogo, Mr. I don't know how to mess his name up. Mr. You know what I'm talking about, Mr. Gasper, people, brown people. Give them a position where they can give them the training, the $2,000 training everybody else got that sits behind desks that don't use them. Give them those trainings so they can best serve their community. They need those supports. I've had this nonprofit, the status, not, just for a few years, but been doing the work. And that was the biggest struggle for me, was we have the training for you. We have the training, but you got to come up with the $2,000. That's why a lot of people don't have, they're not able to serve their community. So open the door for that. Bring people to the table. Don't just ask us, you're a CBO, so let me come and ask you what you want. I'm gonna take what I want from the conversation, and we'll take it to the, and sit and try to figure out what we're gonna do with that. Bring people to the table that serve the community. You can't do nothing because you're sitting at a desk. You know what I mean? Like, you're not after hours helping and working with families. Bring those people to the table, give them the training they need so they can go back and serve their community. So I hope I didn't sound like I was fussing, but it's frustrating. It's very, very frustrating. All the CHWs, they need to have scholarships. Make those people in the community, like Mr. Dogo was talking about, put money to the side so they can become community health workers, because they just don't have the title. Make a place for them. Give them the training so they can help their own community, so we can help our own community. Because a lot of times trainings for us, by us, are more effective. I'm done.
Okay, thank you so much.
Thank you.
Appreciate your comments.
If I can just add to what Mrs. Golden had said, I certainly agree I think that part of the issues is that there's so much deep-seated pain in the Black and brown community. When we talk about mental health, if you look at historically, Black folks didn't go to mental health because they would never wanted to be identified as crazy. And so, you got to deal with that stigma and that stereotype of figuring out a way to address this historical perspective of how do you approach mental health without being labeled as crazy. And then the same thing that was said earlier about the vaccine and the fact that, the Tuskegee Institute, that's real to Black folks. And so so the training is important, certainly far as helping our people out. But I also think that the training in regard to the providers, some kind of anti-racist training is also needed as well. So I just wanted just to say that there's some deep rooted issues that we have to address first before we can move forward on providing services to people. Thank you.
Thank you. Invite other members of the board for reflections or questions.
I just want to take the minute, sorry, but before we go, hopefully everyone got the word that there's going to be a conversation this Saturday, December 5th from 10 to 12 p.m. via Zoom, a conversation with the OHA Behavioral Health Director, Steve Allen, where there'll be conversation around how to plan behavioral health in a different way in the Black and African American and African immigrant community. And so please reach out to me if you want information, but I just, in the spirit of what we're talking about today, I'd be remiss if I didn't throw that out there. So thank you.
Thank you. Kirsten?
I just wanted to express my gratitude to all the speakers for taking the time today and sharing your experiences and creating this call to action, but also for the work that you did before COVID and answering communities' need in this critical time as well. So thank you for your precious time and for your efforts to all the folks living in our state. And I just in reflecting on the various speakers, I also wanted to highlight the thread that I heard loud and clear around training, not just, I think highlighting community health workers is critical, and on up all the different levels of providers that are in the health industry. And so how do we identify, I'm just thinking about my work on the High Talk committee and the provider directory, and how do we take these things that are already in place and make them more useful for people finding care that is relevant and welcoming, and so both how do we identify that, how do we grow the capacity for that, is definitely playing in my head, and then just thinking about the different layers of like what are kind of concrete immediate changes that we need to make, and then there's things out of our control that we still need to recognize the impact of. So like Mr. reference public charge, which is not Oregon's doing, but we have to recognize how much of an impact it has in our communities, and how much fear it creates. And so while we should advocate and work to change it on the federal level, but also like how do we in our direct work recognized, and it is our duty to help overcome that. And so just thank you for your time and your work and the challenge that you've laid out.
Thanks, Kristen.
Yeah, I just wanted to thank all the presenters today as well. Really valuable information. Thank you for sharing pretty vulnerable information that is not easy to share. So I really appreciate being courageous and sharing this information. And thank you for the work that you are doing in the community. A couple of things that really stood out for me and things that we've heard quite a bit as well, doing my work with, in community with Native American communities. One is just the lack of resources to be able to do this type of work, right? And then also the other big theme is the lack of trust from community and sort of systems, because systems haven't been responsive, because systems haven't been supportive. And then I'm also trying to make connections. I'm trying to make connections to the earlier presentation that we got from OHA's policy team, right? And I think it's sort of a very kind of, things that I'm taking away. I'm like, if the OHA policy team was, more reflective of the people that are presenting today, I wonder how those policy and legislative agenda that we're presenting would be different. And I also would love to, think about how do we create these sort of ongoing partnerships with community members, with OHA, so that, it doesn't take a crisis like COVID-19 to sort of create these funding opportunities only under a crisis, but that these are more ongoing, established relationships and partnerships that then allow for this organic policy recommendations to create these legislative agendas, right? I would love to know, for example, if the community members that presented today would be like, yes, I see myself reflected in this legislative agenda, and as we think about even OHA's legislative agenda, how can we also think broader about our policies and not be so just only about health, but we think about social determinants of health as well. There's other efforts going on in the community around statewide short-term rental assistance programs. So how can OHA leverage these other opportunities that may not necessarily kind of fit so within the confines of health, but are still going to have a major impact on people's health. So
Thank you, Oscar. Yes, let's go to James and then Brenda. Mr. Kelly,
Can I say something?
Please, yeah.
After then?
Oh, yeah, we'll go to Mr. Kelly, Mr. Gasper, and then Brenda.
Thank you. Sorry.
Yeah, Oscar, thank you for that comment. The problem that I've seen, and I've been in this stuff for a long time, that people create equity in a vacuum. And what I mean by that is it's not inclusive of the whole policy. So my only thought would be that you integrate the whole equity piece in everything that you do, not have it as a separate item. That's my thought.
Thank you. Jess?
Yeah, I just wanted to say, because a lot of the Marshallese, community members that come to our office, they would tell us things like, these things we would have never been able to access if we were to do it alone. And I just want to thank OHA, you know, for giving us this opportunity to be able to help our people. And it's a blessing for us, you know, to go down there and, you know, giving these people money so that they can pay for things. So, you know, on behalf of the Marshallese community, I just wanted to say that thank you for connecting us, because having a Marshallese face in giving resources, just like these folks have been talking about, for us, by us, or just putting somebody or putting an organization that is a Marshallese, it makes it easier. You're coming down to their level, and it's really touching lives. And all this money that you guys have given us, it you know, some folks might say it's nothing, but to the Marshallese community, it's so huge, and it's changing lives in everyday situations that we're witnessing, and that we're talking to these people. And I was talking about bills and a while ago, and I got kind of, you know, but the bills that we're seeing are about $2,000, $3,000 electricity bill, and they're paying their minimums. And when we're able to pay that, it's like a big elephant that they were carrying, that they were so stressed out about. And yes, it goes into mental health and things like that. And it might just be money, you know, but it's helping these folks out. And I just wanted to thank you guys before we end this session. I just want you guys to know that the work that you're doing and helping us, helping our own people, it's really tremendous. So thank you.
Great. Thank you. And we have a bit more time. We have one public comment, so we can go to 11:50 if there's discussion. A fellow board member, Brenda Johnson.
Thank you. Again, I'll echo the comments and the statements by my fellow board members around the impressive nature of the presentation today. So thank you for taking the time and the energy. And what's striking me most at the moment is what it's like to be a big-hearted leader and how to sustain and be resilient in this kind of work. And so I commend each and all of you, and I'm curious, and perhaps my question is directed to you, Crystal. When we think about OHA and the ability that we do in supporting our workforce, and we have conversations about provider retention and provider resilience amidst COVID, amidst all the pressures that are existing in the system. And I'm thinking about our community-based organizations and leaders, much like those on the call today, and others who are doing this kind of heavy lifting work in unprecedented times and in circumstances beyond any perhaps that we've seen in our lifetime. How are we as an agency, how is the board, how are we thinking about it from a workforce perspective, supporting leaders in their own self-care and their own ability to stay resilient in the face of such pressure? That's a big loaded question, Crystal. I apologize for no notice on it, but I'm just really struck by it. And I don't know that we give enough time and attention to this particular question.
I was going to say that that's a layered question. Yeah. I appreciate the question. One of the things that I'm working on now, and we've had some work group discussions in regards to all of the different issues that the communities are facing, from the African American, the African immigrant, and the African refugee communities. We came together in various work groups to be able to elevate the issues and talk about those. And a lot of the some of the concerns were, it's not just like, it's social determinants of health. It's not just direct health. And it's in regards to workforce retention. It's in regards to helping organizations build infrastructure. It's in regards to helping the organizations be able to understand and learn how to be more sustainable. Even amidst some of the process, all the money has been great, and a lot of the calls that I've received are in regards to, okay, we want to do this right. What's the correct way to be able to make sure that we're giving and we're being equitable with our communities to give the money out? And I mean, some of those concerns, I think, could have, if there was maybe processes in place that could have helped to train the communities on how to deliver the service, not deliver the service, but the resources, how to, maybe you needed forms development, maybe you needed to understand what the processes are to make sure you had all of the different languages available to you to be able to help in communicating the concerns and the issues and with the community. But some of the, I mean, there's a lot of things, and I would be more than happy for us to come back again. But there are a lot of things that we are in the process of working through, and I'm talking with community and also working with, she's a treasurer, I'm trying to remember, Brenda. She is the state business partnership across the state, and working with her and trying to identify resources, and because some of the issues and concerns were workforce development, economic sustainability. So those are some of the things that we're in the process of trying to put together pieces for the communities to then be able to work through and see how that could assist them in providing different trainings to be able to help them to be able to do COVID, to be able to help them to be able to provide workforce development for the organization and the people within their communities. So, I mean, there's a lot of things and I, you know, going on, but it's little pieces here and there. And we have work groups we're going to be rolling out for a lot of the community, and I try not to email as much, but at least once a week saying this is an opportunity, do you want to participate? So, I mean, but there's a lot. It just seems like there's so much, and just trying to step back and methodically address each issue as it's been brought up from the community. I don't know if that answers your question, but.
Thank you, Crystal and Brenda, for that great question. Tanya Golden, I got a message that you wanted to make a comment, and we'll probably have to wrap it up after one more.
I'm gonna say fast. And from the community-based organizations to the OHA, I just want to remind you that whatever we do, that we are focused on not causing more trauma and remembering to do no harm. Whatever we do, a lot of people are saying, I feel like I was in a welfare line just waiting for my $500 stipend. You know, some people are being traumatized by the way that they're getting their services. And so just remember, like, we want to help, we want to support people, not help them, we want to support them, but be focused on not creating more harm.
I want to thank all of our presenters for insightful, meaningful, heartfelt, courageous discussion. I'd like to thank my fellow board members. Thank again to Crystal Marion for helping manage the discussion. Really appreciate that. And I think this reinforces the importance of us continuing these sessions as a board, because I think it informs both the policy board as well as OHA. So thank you again for your time, your good work in your communities. We'll now turn to public comment. I understand we have one comment. Let's see. Chuck Erickson from the director of the Clam Diggers Association of Oregon has a public comment. We have 2 minutes, please.
I'm trying to get my video to work.
Lower left part of your screen.
Yeah, it says you cannot start the video because the host has stopped it. Can you hear me?
Yes.
We can hear you. Michelle or Tara, do you change the setting, or should we just go forward? There we go. We can see you now.
Okay. I'm Chuck Erickson. I'm the director of the Clam Diggers Association. Can you see this picture?
We can see you. The picture doesn't come through very well.
Okay.
If you
Well,
ready,
I sent this picture to you folks. This is a couple of people clam digging in an area that's unsafe, and it's happening coast-wide. No safe areas have been established, and we're seeing that the health authorities making recommendations for eating shellfish and they're not taking in concern of the real world conditions. We have people that are harvesting shellfish in sewer effluent areas, municipal discharges, and no testing, no nothing. So, and we're also concerned about the health advisories were not put on the in the fishing synopsis. Wondering why. So now I can't hear anybody, so I'm not sure if I'm on or not.
We can hear you well. We can hear you fine. Thank you. Thank you for your comment.
And the other comment is we noticed that in your health advisories, there's nothing written in Spanish. And we're wondering about that.
Mm-hmm.
At least the title, like something in Spanish.
Mm-hmm. Mr. Erickson, thank you for your comment. I think this is an important health issue, and would also encourage you to raise this with the Public Health Advisory Board, which works.
I have. I've written them multiple times.
Okay.
And they don't seem to. They don't see it as a problem to hide the FDA's mercury warnings for tuna, halibut, and rockfish. There's no warnings on crayfish. Mm-hmm. There's plenty of tests. There's been testing done in the Columbia and the Willamette, and there's not a single health warning on this. And I brought it to their attention, and they have not. All they keep I don't, I look these people up. These people I'm dealing with they don't fish. They don't do any of this. So I don't know if they have the expertise to even be doing this. And
thank you very much for your comment. We'll take that under consideration. And I know that group well, and we'll raise it with them. So thank you for joining us.
Okay, thank you.
We need to move. All right. Well, I want to thank all of our presenters today again for their presentations, for sharing their perspectives. I found that you really, and we also want to thank fellow board members for the reflective discussion, and also the OHA for the great work they're doing as we close out the last meeting of 2020. It's been quite a year. We have seen great challenges. I really am proud of all of your work. Really inspired by all of your work to address the health equities that COVID-19 has created in our state. So thank you for your good work. It's an honor to work with all of you, to see your good work, to support that good work. I look forward to a better 2021. We will start the meeting in January, where our first meeting will be January 5th at 8:30 a.m. Of 2021. During that meeting, we will discuss the Healthcare Workforce Committee's need assessment and the Sustainable Healthcare Cost Growth Target Implementation Committee's final recommendation report. Fairly technical presentation, so I remind the board members that we have the opportunity to participate in ongoing educational webinars. These have been a great, I think, asset to all the board members, as well as the public that attends these are welcome to attend these webinars. On December 15th, OHA, in collaboration with the Healthcare Workforce Committee, will host a webinar for members and the public on biennial needs assessment of the Oregon's healthcare workforce. This will look at the historical trends, impacts of COVID-19, and the expansion of telehealth and specific assessments of workforces on traditional health workers, healthcare interpreters, behavioral health providers, and oral health providers. Again, this is December 15th from 8 to 9 a.m. Please put that on your calendar. We look forward to that. And then there'll be a second webinar on December 22nd from 8 to 9 a.m. 8 to 9 a.m. OHA staff, in collaboration with the Sustainable Healthcare Cost Growth Target Implementation Committee, will host a webinar for members in the public, which will focus on the accountability of the healthcare cost growth target work. That is, when a payer or provider or organization that does not meet the healthcare cost growth target, what will be the consequences? We look forward to that webinar as well. Once again, thank you all for a productive year for 2020. Wish you all a happy new year and look forward to rejoining you on January 5th in 2021. Thank you, everyone. Have a great and safe and socially distanced holiday. I look forward to seeing you in January.
Thank you.
You.